On behalf of the organizing committee and scientific committee, I would like me, Dr. Eli Saar, to welcome you to the symposium entitled Cardiovascular Disease Promotion, Prevention and Rehabilitation. And I would like also to introduce Dr. Anthony Khouri, cardiologist, who will be the main speaker also. We will be covering, inshallah, all the topics and objectives of this symposium. And we will be ready to answer all your questions. ملاحظة بس we may switch between sessions in the same day. But all the topics, as I said, will be covered. So, as you know, the aims of this symposium is to update professional skills and knowledge so participants will be able or will be up to date with best practice and evidence-based practice related to cardiac disease. Also, we will be providing updates in major critical presentation in cardiac disease, like myocardial infarction, chest pain, etc., and highlighting the new updates in the cardiac disease and rehabilitation, emergency medicine. Gaining new knowledge of current evidence-based practice related to the holistic care of cardiovascular medicine and surgical patients. We're gonna help care teams make confident and safe care and clinical decisions, understand how to build and education recovery plan for all patients, providing participants with the opportunity to advance their clinical skills in case of cardiac arrest. So inshallah كل التوبكس والobjectives هنغطيهم. نبتدي مع ان شاء الله مع دكتور أنطوان الخوري, cardiologist, with the topic risk factors for cardiovascular diseases, early prevention, for the first session. And the second session will be also with him, dietary therapy and prevention of cardiovascular disease. نتمنى السيمبوزيوم يكون ناجح, وبعطي الكلام لدكتور أنطوان. دكتور أنطوان.
مرحبا للكل ورمضان كريم. بس أول شيء بدي أتأكد إذا عم تسمعوني مزبوط, لأنه عم تسمعوني. عم تسمعوني دكتور إلي؟
Yes, واضح الصوت. Yes.
Okay. رمضان كريم للكل. So I'll start by introducing myself. أنا أنطوان الخوري. I'm a cardiologist from Lebanon. وهلا أنا I'm working عم بشتغل بفرنسا. اليوم رح نعمل رح أعطيكم 3 topics and mainly on cardiovascular disease, early prevention, to focus on prevention. So I will start. Are you عم بتشوفوا my slides صح؟
Yes, واضح.
Okay, yeah, I will start. So today we will talk about risk factors for cardiovascular diseases and focus on early prevention. So my talk is based on the most recent guidelines, which are the European Society of Cardiology Guidelines 2021, and will include a bit also of the American College of Cardiology Guidelines. So I'll start by the goal of prevention and guidelines. So we need to target the population to decrease the ASCVD. ASC is the atherosclerotic cardiovascular disease burden. So we have two ways. So it's either we need to do prevention of ASCVD occurrence in apparently healthy people or people with known cardiovascular disease risk factor. So people that doesn't have actually cardiovascular disease, but either are healthy or are have cardiovascular disease risk factor. We'll talk about risk factors later on. And the second target is to reduce the progression or prevention of new development of atherosclerotic cardiovascular disease in patients already have cardiovascular disease. So we have two options, either people that don't have cardiovascular disease or people that already have established cardiovascular disease, and we need to do prevention in both these groups. So we have two methods of screening the risk factors. So the first one is a systemic one for the general. Hello? Are you hearing
Yes,
me?
yes, واضح.
Okay. So we have to screen for the risk factors. We have two methods. The first one is a systemic method, which is used for the general population. We need to screen the general population, or we need to target a subpopulation in this general population, meaning that we need to target patients with cardiovascular risk factor. The second method is to do opportunistic screening. So opportunistic screening is meaning that when a patient presents to the hospital, for example, for an infection or for any other disease, we need to check in this patient if he has any risk factor to develop cardiovascular disease later on. So we call this an opportunistic screening. So patient not coming for a cardiovascular disease checkup, but we check him to see if he has any cardiovascular disease. So as you all know, when we need to mention guidelines, the guidelines will you will see in the guidelines we have class 1, class 2, class 2A, class 2B, and class 3. So when we say class 1 recommendation, it means that it's recommended and it's indicated. So we need to do this. When we say class 2A, it means that it should be considered. So this therapeutic option, for example, or this diagnostic option should be considered, and we have to do it. When we say class 2B, it means that it may be considered. It's not very recommended, but it's better to do it. And when we say class 3, it means that it's not recommended and we should not do it. It's harmful for the patient, actually. And when we say it's level of evidence A, it means that we have multiple clinical trials supporting this idea. And when we say level of evidence B, it means that there's only one randomized clinical trial supporting this idea. It's a bit less recommended than level of evidence A. And when we see level of evidence C, it means there is no big trial on this topic, but it's expert opinion. So a doctor, which is an expert in cardiology, for example, can give his opinion about a topic, and it will be included in the guidelines. It's very important to understand this because when we continue, we'll see it a lot in our slides. So the recommendation for cardiovascular risk assessment. So we need to do systemic cardiovascular disease risk assessment in all individuals, especially individuals that have a family history of premature cardiovascular disease. So in a family, a death, for example, at an age of 30 or 40 that was unexplained, we need to screen the family, the children, for cardiovascular disease. Patients that smoke, or patients that have hypertension or diabetes, or hyperlipidemia or obesity, all these patients should be screened systematically for cardiovascular disease risk, and it's class 1 recommendation, so we have to do it. It's very recommended by the guidelines. While class 2B recommendation is for people that are above 40 years of age, and for women that are above 50 years of age, meaning that women that are postmenopausal, so they have increased risk of cardiovascular disease. In this case, it's class 2B indication to do cardiovascular disease risk screening, because here they consider that older age is a risk for cardiovascular disease. It's class 2B, meaning that we can do it, but it's not class 1, so we are not obliged to screen everyone above 40 for cardiovascular diseases. And if we do this, we don't have to repeat the screening every year. We need to repeat it 5 years later. So if we screen, for example, a patient of 40 years of age for cardiovascular disease, and this patient is not known to have cardiovascular diseases, we repeat screening not before 5 years' time. And opportunistic screening of blood pressure in adults at risk of the development of hypertension, such as or people that are overweight. You know that overweight patients are at risk to develop cardiovascular disease and to develop is mainly hypertension. So all obese patients, regardless of age, should be screened for cardiovascular disease when they present to the doctor or to the hospital for any other reason. So we need to screen them for cardiovascular disease because we know that obese patients are very associated with cardiovascular disease and high blood pressure. And you can see the last one, which is class 3 recommendation, meaning that we should not do it routinely. So systemic risk cardiovascular disease assessment in patients that are less than 40 or women that are less than 50, meaning that women that are premenopausal, it's not indicated to screen them systematically unless they have other reasons like smoking, diabetes, or obese. So we screen them. But if we have healthy individuals, less than 40 a man and less than 50 female, we should not do systematic cardiovascular screening. So what are the major risk factors for cardiovascular disease? As you all know, hypertension is one of the leading risk factors for cardiovascular disease, as well as diabetes mellitus, dyslipidemia, and smoking. And we have a lot of risk modifiers. We'll see later on this slide that we have a lot of risk modifiers that can increase cardiovascular risk and that can potentiate the effect of the traditional risk factors that we already mentioned. So we will detail this later on the next slides. So we start by hypertension, which is a major risk factor for cardiovascular disease. Hypertension is a major risk factor for atherosclerotic cardiovascular disease, heart failure, and cardiovascular deaths. And we know that hypertension can lead to coronary artery disease as well, which is a major cause of death. And it can lead to stroke, so it can lead to cerebrovascular accident as well. So when we treat hypertension by lifestyle modification, for example, diet or exercise, or by adding medications, will decrease cardiovascular mortality, decrease atherosclerotic cardiovascular disease, and decrease the incidence of heart failure and heart failure hospitalization. So we have decreased cost of hospitalization. The second major risk factor, which is diabetes mellitus, either type 1 or type 2, it's the same risk. It increases cardiovascular disease by 2 times. So it's increased the risk to develop cardiovascular disease 2 times. And treating diabetes correctly will reduce cardiovascular disease complication and will reduce diabetes-related complications as well. The third major risk factor, which is smoking, which is very common and which is endemic in our region, increase 5 times the cardiovascular disease as compared to non-smoker. And it will decrease the average span of life. So meaning that if average age of a non-smoker is 80, the average age of a smoker is around 70 or 65 due to risk of development of cancer, cardiovascular disease, which are the 2 most leading cause of mortality, cancer and cardiovascular disease, and they are both directly linked to smoking. So when we stop smoking at any time, we will decrease cardiovascular risk within the next 5 years. So it's very beneficial to ask the patient to stop smoking. The fourth major risk factor, which is dyslipidemia, it's high blood lipids, is a well-known also risk for developing atherosclerotic cardiovascular disease, and treating hyperlipidemia will reduce cardiovascular mortality by 22%. And for example, if my LDL level now is 140, treating hyperlipidemia correctly, meaning that we have to reduce it minimum by 40, this will to 100. So from 140 to 100, this will reduce the risk of cardiovascular mortality by 22%, which is a major number. So we have to do it. So we have also, other than risk factors, we have risk modifiers. Risk modifiers means that they will influence cardiovascular disease and influence the risk factors, increase the effect of risk factor on the heart, which the most common risk factor is psychological stress and mental and physical stress. So any type of stress will cause harm to the cardiovascular system and will increase mortality on the long term. Ethnicity as well. We know that Black American have a higher rate of cardiovascular disease, as this is related to genetics. So ethnicity, skin color, and the genetics will increase cardiovascular disease. Family history of cardiovascular disease. For example, if a male patient had a cardiovascular disease at an age of less than 55 years of age, we should be careful to screen his children for cardiovascular disease later on, and you consider this a risk modifier. Obesity as well, as we said, it's a risk modifier as well. Environmental exposure, for example, high pollution level will cause chronic hypoxia, for example, and will lead to myocardial ischemia on the long term. Low socioeconomic status, for example, because as you know, in countries of the third world where we have economic crisis, the patients will seek medical care a lot less than countries that with high income. So patients will not do follow-up visits to his doctor. So this will increase the risk of cardiovascular disease and cardiovascular mortality on the long term. It's also encouraged for patients that live in high pollution areas. It's recommended to ask these patients if they can try to avoid long-term exposure, because as we said, pollution is a risk modifiers, and now pollution exposure is in the guidelines as class 2B recommendation to try to avoid the polluting environment in order to reduce cardiovascular disease on the long term. Moving now to special conditions. As you know, chronic kidney disease is a disease affecting the kidneys, and chronic kidney disease, even in patients without diabetes mellitus, is an indication to screen for atherosclerotic cardiovascular disease in patients with chronic kidney disease, because as you know, kidney disease is linked to heart disease, and kidney disease can precipitate the coronary artery disease. For example, we know that a lot of patients with chronic kidney disease have a degree of coronary artery disease at the stage of their lives. So we need to always screen for cardiac disease in patients with kidney disease. And as you know, cancer, it's recommended also to monitor cardiac dysfunction using imaging technique, meaning that we have to do echocardiogram after the treatment with some chemotherapy, for example, or some immunotherapy. As you know, for breast cancer, we have Herceptin, which is a medication to treat breast cancer. It's associated with a lot of cardiotoxicity. Same for anthracyclines, which are used for other types of cancer and for lung cancer, for example. Sometimes we have irreversible damage due to chemotherapy or due to immunotherapy to treat cancer. So we need to be very careful in patients that are being treated for cancer. We need to do heart ultrasound in a periodic basis in order to screen for cardiovascular disease and prevent cardiovascular disease. It's very important, and there is now guidelines on cardio-oncology in patients that are treated for multiple types of cancer by the use of chemotherapy. Same applies for patients with COPD, which is chronic obstructive pulmonary disease, which is a disease of the lungs and the airways. It's recommended to screen all patients with COPD for atherosclerotic cardiovascular disease, because you know patients with COPD will have lower level of oxygenation and will have lower oxygen levels that will reach their heart and the myocardium of the heart. So we'll have a state of chronic ischemia. So we need to avoid this, and we need to screen for cardiovascular disease at an early stage of COPD. Multiple inflammatory disorders as well increase cardiovascular disease in adults, like autoimmune diseases, chronic inflammatory conditions, and mainly patients with rheumatoid arthritis, which is a disease affecting the joints, especially of the upper limbs. Patients with rheumatoid arthritis have a 1.5 time increase in their cardiovascular risk and cardiovascular diseases. So we need to screen for cardiovascular disease at one point in patients with rheumatoid arthritis. Same applies for migraine, which is very common migraine in our population. Migraine should be, especially migraine with aura, meaning that patients that have symptoms associated with migraines, In this patient, we need to screen for cardiovascular disease because we found in a lot of studies that patients with migraine headache have increase in their cardiovascular disease progression and cardiovascular disease incidence. So it's important to screen it, and it's now mentioned in the guidelines as class 2A. So sleep disorders as well. For example, that patient that have obstructive sleep apnea, meaning that patients that have desaturation at night due to obstructive sleep apnea. In these patients, screening for atherosclerotic cardiovascular disease is indicated as class 1. And we need to refer this patient to a specialist, a sleep specialist, who is usually a pulmonary doctor. He will screen for sleep apnea in patients with cardiovascular disease, because as you know, sleep apnea will increase the risk of cardiovascular deaths, will cause hypertension on the long term, will cause coronary artery disease, will cause atrial fibrillation. So it's very correlated with cardiovascular disease. Mental disorder is very important, and is most of the time not diagnosed properly, because we saw in multiple studies that mental health disorders like stress or anxiety or depression are all associated with increased cardiovascular disease on the long term. So it's class 1 recommendation to screen for mental disorder in all patients that have cardiovascular diseases. Now moving to female population, especially pregnant females that develop preeclampsia. Preeclampsia is a cause of high blood pressure in pregnancy and proteinuria. So patients will start to lose proteins from their kidneys and will have very high blood pressure during pregnancy. For these patients, after delivery, we need to continue looking for hypertension and diabetes on the long term, because we know that patients that develop high blood pressure during pregnancy have a risk to develop high blood pressure later in their lifetime. So we need to screen for hypertension and diabetes in this population. So also, patients with polycystic ovarian syndrome, which is a disease affecting the kidney or the ovaries. We will have multiple cysts in their ovaries and the both ovaries. So we found that patients with PCOS, polycystic ovary syndrome, have a high risk of developing diabetes later on. So we need to always look for diabetes by measuring fasting blood sugar, or measuring hemoglobin A1C percentage in order to diagnose diabetes later on. Patients that deliver also premature babies or stillbirth babies also need to be screened for hypertension, because in studies we found a correlation between premature delivery and hypertension in the female later on in life. So how to estimate cardiovascular risk? In order to estimate cardiovascular risk, we divided patients in 5 categories. The first category is for patients that are apparently healthy without any disease, that don't take any medications. Patients that have chronic kidney disease, patients that have diabetes mellitus, and patients with any family history of cardiovascular disease, and patients with established atherosclerotic cardiovascular disease, meaning that patients that have coronary artery disease, heart failure, or any other type of heart disease. So in order to estimate the risk, we have scores. We have a score called, we'll discuss it in a later slide, but we have a score called score 2, which is for patients that are less than 70 years of age. And we have a score 2OP, which is used for patients that are above 70 years of age. And this score will give us an idea of the risk of fatal and non-fatal cardiovascular disease that might happen for this patient in the next 10 years. And this score is based, will have a number which will classify the patient as a low risk, as a moderate risk, as a high risk, and as a very high risk. And in this score, we will use the age of the patient, the sex, smoking history, blood pressure, and cholesterol level. So based on this score, they did multiple studies in multiple countries. As you can see, countries that are colored in dark red, meaning that in these countries, there is a very high risk of cardiovascular diseases. And in the Middle Eastern countries, the Arab countries, it's a dark red color, meaning that it's very high risk to develop cardiovascular disease, and we can correlate this because of the bad lifestyles, the smoking, and the diet, and also the genetics, because you know that cardiovascular diseases also can be transmitted genetically. So in these regions, for example, as compared to Europe and Western Europe, for example, France or Germany or Spain or the UK, these countries have very low risk of cardiovascular diseases as compared to our countries, for example. So here is an overview of this score 2OP score that we use. You can see here on the left, we have the systolic blood pressure. So we have here the sex, women or men. We have the smoking and the non-smoking, and we have the non-HDL cholesterol level. And when we do all this calculation, we'll end up with a score. And this score will indicate that if this patient is a low risk or moderate risk or a high risk to develop cardiovascular disease later on. So as you can see here, for patients, for example, that are less than 50 years, if we get a score of less than 2.5, it means that the patient is a low to moderate cardiovascular risk. So we have a low risk to develop cardiovascular disease. If a patient has a score between 2.5 to 7.5% and less than 50, this is a high cardiovascular disease risk. And if the score is above 7.5% in patients that are 50 years of age, this is a very high risk to develop cardiovascular disease. And though you can see here on the table, we will not go into the details. We have, for different age group, we have different score and different classifications. Moving now to patients that have CKD, chronic kidney disease, without diabetes or without atherosclerotic cardiovascular disease. So CKD alone. If the patient has CKD with a clearance glomerular filtration rate of between 30 to 44 and an albuminuria of less than 30, or if he has a clearance between 45 to 59 and albuminuria of 30 to 300, or clearance above 60 and albuminuria of more than 300, this will automatically classify the risk of this patient at high risk, regarding of the score we get and regarding of his age. CKD with any of the following conditions is a high risk for cardiovascular disease, so regardless of the score we get. If we have severe CKD, for example, meaning that GFR is less than 30 or GFR between 30 and 44 and albuminuria of more than 30, this is a very high risk patient to develop cardiovascular disease, regardless also of the score that we calculated. So CKD is a high risk and very high risk condition for cardiovascular disease. Same for familiar hypercholesterolemia. For example, patients that are born with familiar high blood lipids at birth, these are very high risk patients because they have very high level of total cholesterol and very high level of LDL and very high level of triglycerides. This is very risk for developing cardiovascular at a premature age. Patients with type 2 diabetes mellitus that are well controlled or that are diagnosed by the diabetes duration of less than 10 years, these are moderate risk to develop cardiovascular disease, while patients that are diabetic for a longer period of time or that have diabetes, for example, for more than 10 years, these are high-risk patients to develop cardiovascular disease. So timing of diabetes is very important in order to classify the patient as moderate risk or as a high-risk patient. So moving now to patients with diabetes and already established atherosclerotic cardiovascular disease. So these patients are very high risk of cardiovascular disease recurrence and very high risk of coronary artery disease occurrence as well. And patients that have already developed an acute myocardial infarction, an acute coronary syndrome, for example, a stroke in their lifetime, they will have very high risk of recurrence of cardiovascular disease later on, regardless of the score we get, regardless of the score OP that we calculated. So these patients will automatically be classified as very high risk patients. So now, how can we do interventions in order to prevent the occurrence of cardiovascular diseases? So we have a stepwise approach. First of all, as a prevention for everyone, so all the conditions that you already mentioned, we should make sure that the blood pressure is always, systolic blood pressure is always less than 160 millimeter mercury, and we have to also make sure that all patients will stop smoking if they smoke. This is for everyone. And after that, we need to go to the first step. We need to reduce the blood pressure to less than 140 systolic and even to less than 130 millimeter mercury if we can. And we need to reduce LDL level to less than 100 in most patients and less than 70 in specific conditions that we will discuss later on. And the step two depends on each category. We'll see that on the next slide. So this slide, you can see that we'll do intervention in apparently healthy patients, how to prevent the cardiovascular disease in these healthy patients. So as a step one, as we said, we need to encourage smoking cessation and lifestyle recommendation. And we need to make sure that the blood pressure is always less than 160 millimeter mercury. And this is a class 1 recommendation. After making sure that the patient is in this condition, we see the age of the patient. If the patient, for example, has an age of less than 50, we then calculate the score 2 that we already discussed, and we'll have a risk. We have a percentage. We have a low risk, less than 2.5. We have a moderate risk, 2.5 to 7.5, and a high risk, which means above 7.5. If the patient has a low risk patient, we can proceed, do no additional prevention goals. We can stop here because the patient is young and has a low risk to develop cardiovascular disease, then we can stop here. If the risk is high, meaning that you have a risk of above 7.5, in that case, we should make sure that the patient has a blood pressure of less than 140 systolic and even less than 130 systolic. So we should reduce his blood pressure in order to avoid cardiovascular diseases. And we should make sure that the lipids LDL level is less than 100. Same applies to the other age groups of between 50 to 69 and above 70. We divide them according to the score. And for example, for patients that are above 70 years of age and has a low risk, which means that a score of less than 7.5 here, we stop intervention because the patient is already at an older age, and if we lower his blood pressure to an excessive amount, harmful for the patient, because all patients, we have to avoid hypotension in these patients. So excessive treatment sometimes can be harmful for this patient. So we have here a less aggressive approach for patients that are above 70 years of age. Moving now to patients that are already have an established atherosclerotic cardiovascular disease, meaning that they have already coronary artery disease, they already had a stroke before. What intervention can we do to prevent recurrence of these cardiovascular diseases at a later age? So the step one here, we have to stop smoking and we have to do lifestyle modification. We have to encourage exercise. We have to correct the diet. We need to reduce the blood pressure to less than 130 millimeter mercury if tolerated, which is a class 1 recommendation. We need to reduce LDL level here to less than 70 milligram per deciliter and not less to 100. We have to be more aggressive with treating the hyperlipidemia. And we need here to introduce an antithrombotic therapy. For example, we need to introduce aspirin in order to prevent the recurrence of the atherosclerotic cardiovascular disease later on in life. And when we finish with step one, we need to try to further enhance patient condition. We need to make sure, step two, that his blood pressure is always reduced. And at the second stage, we need to try to reduce his LDL level from less than 70 to less than 55, because reducing LDL level to less than 65 has mortality benefit on the long term. And we can add sometimes a second antiplatelet drug for patients that are at very high risk of cardiovascular diseases. For example, coronary artery disease patients, we can add, in addition to aspirin, we can add a clopidogrel, which is a second antiplatelet that prevents platelet aggregation. So it's very recommended to do it a stepwise approach. I can't move the slides. I don't know what's okay. Moving now to patients with type 2 diabetes mellitus. Step 1 is same for everyone. We need to stop smoking. This is very important to encourage patients to stop smoking. And we need to make sure that their hemoglobin A1C, which reflects the average glucose level in the last 3 months, is to less than 7%. And after we do this, we need to see these patients if they have established atherosclerotic cardiovascular disease in the past or not. If they don't have established atherosclerotic cardiovascular disease, meaning that these patients have a moderate risk of recurrence and have a moderate risk of cardiovascular disease later on, and this is class 3 recommendation. But patients with established class atherosclerotic cardiovascular disease in the past have a very high risk of mortality from cardiovascular disease, and these patients should have a blood pressure of less than 130, as we said in the previous slide, and should have an aggressive LDL reduction to less than 70. And we should add aspirin for some patients with high risk. And we need to add also a medication which is an SGLT2 receptor inhibitor, which this medication will act on the kidneys to prevent glucose reabsorption. And this medication is a new medication. It's very effective as well on the cardiovascular system. So it helps diabetes and it helps the heart at the same time. So it's very recommended to add it early on in the patients with diabetes and patients with diabetes with a high risk. And the stage 2, as we said from the previous slide, we need to push more and we need to try to reduce the LDL level now to less than 55 milligrams per deciliter and not less than 70, which is very helpful for prevent recurrences in these patients. So now, for lifestyle interventions, we need to encourage all patients to do. We need to encourage them to do activity. So we need to do at least 150 to 300 minutes per minute a week of moderate intensity, or 75 to 150 minutes a week of vigorous intensity aerobic physical activity. So it's class 1A to encourage patients to do physical activity. And for patients that cannot tolerate to do this much physical activity, we need to ask them to do it as their abilities and as their health condition allows. So we need to ask the patient to do the maximum possible physical activity a week. And this is very helpful in reducing cardiovascular disease, reducing hypertension, reducing heart failure incidence, and it's very helpful as well in patients with heart failure. Okay. So as for the diet now and nutrition and alcohol, we need to encourage patients to have a Mediterranean diet, which means a diet that is rich in milk and diet with a low cholesterol. So we need also to replace saturated with unsaturated fats. We need to refer patients to dietitians in order to better control their diets. We need to reduce salt intake because salt intake is associated with increased risk of high blood pressure. We need to increase fiber in the diet because increasing fiber will reduce cholesterol level. We need also to reduce alcohol level and limit alcohol level, especially in patients that are alcoholic, because this is a risk of developing dilated cardiomyopathy later on or any other form of heart failure. And we need to encourage patients also to eat fish once per week at least, in order because it's rich in omega-3 level, which will lower the lipid level as well. And we need to restrict free sugar consumption and reduce a lot the sugar inside the diet. So for the diet, it's recommended to decrease salt intake to less than 5 grams a day and increase fibers to 30 to 45 grams of fiber per day, and increase fruits per day. You have 2 to 3 servings of fruits per day, and increase the vegetable also 2 to 3 vegetables serving per day. And the red meat should be reduced to less than 350 to 500 grams per week. And we need to recommend a fish diet for 1 to 2 times per week if possible. And we need to add nuts also, because nuts are very effective. We will discuss this in the second presentation today, which is related to diet. And we need to decrease sugar consumption, sugar beverages and soft drinks, and fruity juice, as we said, because sugar is associated also with increase in cardiovascular mortality and cardiovascular disease incidence. So as for the body weight, it's recommended to ask patients that are overweight to try to lose weight, because when a patient lose weight, automatically the blood pressure will drop, the dyslipidemia, or the lipid level will improve, and the risk of developing type 2 diabetes will improve. And losing weight, meaning that we need to encourage patients to have a healthy diet, because a healthy diet will automatically improves the patient weight. And if the patient is unable to reduce his weight by diet or by exercise, we need to recommend the patient to a surgeon to perform a bariatric surgery, a sleeve gastrectomy. This will help patient lose weight in a fast way if the surgery was done properly. So it's very important to encourage patient to lose some weight. As for the psychologic diseases, we said that psychological diseases increase the risk of cardiovascular disease, and we need to ask the patient to refer him to a psychotherapist if we think that the patient is at risk of developing mental disorder associated with cardiovascular disorder, and we need to add treatment, antidepressive treatment, and SSRI, which is serotonin reuptake inhibitor, for patients with congestive heart disease that have major depression as well. But for patients with advanced heart failure, it's not very recommended to use these type of medications, because they have a lot of side effects and they can cause arrhythmias, ventricular arrhythmias, and fatal arrhythmias. They can induce modification on the heart electrocardiogram, and they can prolong the QT segments, so they can induce major problems on the cardiovascular disease when the heart is already very weak. So we need to be very careful with these type of medications in these patients. Now, as when we move to smoking, we need to ask the patient to try to stop smoking and not just reduce smoking. We need to try to ask him to stop smoking. And if the patient is unable to stop it, or if the patient stops then relapse after on, we have to use nicotine replacement therapy. Nicotine replacement therapy, which can come as a patch. We can put a patch on the skin of a patient. It will give him nicotine continuously over 24 hours. Or we can give nicotine pills, which is like a chewing gum. The patient can take them as needed during the day. Moving now to lipid management. Lipid hyperlipidemia is also is a very risky disease. We need to be careful to avoid cardiovascular disease later on. So for all patients that have high LDL levels and hyperlipidemia, we need to use statins. Statins is the gold standard treatment for the treat hyperlipidemia, like atorvastatin and rosuvastatin, which are these two drugs are high intensity statins, so they can decrease statins significantly. And we can combine statin a second drug, which is called ezetimibe. Combination of these two drugs is very effective in reducing the LDL level and the total cholesterol level. If we think that with these two drugs, the patient has still an LDL level above target, meaning above 70, as we said, in diabetes, and above 55 in patients with established coronary artery disease or cardiac disease, we need to add another medication called the PCSK9 inhibitor, which is medication given intravenously. We can give it once a month, and it has very, very important reduction in LDL level. And we have a lot of patients that can tell us that they are intolerant to statins, that they have a lot of side effects to statin, for example, muscle pain and liver problems due to statin. We can start by ezetimibe as an initial therapy instead of using a combination of statin and ezetimibe. So we can do this. And we need to also know that statin therapy is not recommended for pregnant patients or for patients that are not using contraception and are willing to be pregnant, because it can cause a lot of problems to the babies. So even for hyperlipidemia, not just to treat high LDL level, for high triglyceride level, when you have triglyceride above 200 milligram per deciliter, statins are also effective. And if statins alone does not reduce the triglyceride level, we can add fenofibrate or bezafibrate to the statin regimen in order to treat hypertriglyceridemia. And we have another third drug called icosaptan ethyl 2 times 2 gram per day, which also can be used in order to treat hypertriglyceridemia. So statin is recommended for all patients that have already a coronary artery disease, for example, even if these patients does not have high LDL or high cholesterol level. We need to add statins because we found that in multiple studies that adding statins, even in normal lipid level in patients with already established cardiac disease, will improve mortality benefit on the long term. And even for older patients above 70, we can give them statins, but we need to be very careful in these patients because statin in old age can cause a lot of problems like muscle weakness, like joint pain, like liver injury. So we need to be very careful in those patients, especially in patients with significant renal impairment and patients that are taking other drugs. So we can have a drug interactions with the statin and we can have a lot of side effects. So it's important to know that we can use statin and ezetimibe combination in chronic kidney disease, even for patients with end stage, so stage 3 to stage 5 chronic kidney disease. And we can continue them in dialysis patients if we have already a patient on dialysis that have cardiac disease. But if a patient has kidney disease on dialysis without established cardiac disease, it's not recommended to use statins because statins in renal failure can cause also a lot of side effects. So it's not recommended to use statin in patients with dialysis, but without atherosclerotic cardiovascular disease. So it's a class 3 recommendation, as you can see here on the slide. So it's not recommended. Moving now to high blood pressure. High blood pressure measurement. As you can see, the hypertension is classified on the normal blood pressure is optimal blood pressure is less than 120. The normal blood pressure is between 120 and the 129. We can say its blood pressure is high when it starts to be above 130 systolic and above 85 to 89 millimeter mercury diastolic. And grade 1 hypertension is a blood pressure above 140, so between 140 and 159, and grade 2 is between 160 and 179. Grade 3 is above 180 systolic. So it's very important to classify and to do it correctly because classification of blood pressure will help us treat the patient and help us know what drug or what combination of drug to give depending on the grade of hypertension. So it's recommended to classify blood pressure, as we said. So grading stage 1, stage 2 hypertension. It's very important for treatment, and it's for the diagnosis of hypertension. We have two options. It's either we tell the patient, for example, we give him an ambulatory blood pressure monitoring. It will measure his blood pressure every 30 minutes. And the second day, the patient will come to the office and we'll have an average of his blood pressure during the day and during the night. It's very recommended to do this to diagnose high blood pressure. We can do this also in the office, in the clinic. When we see the patient, we do repetitive measurements and on multiple visits, not just on the same visit. We need to do it on multiple visits. And we can diagnose hypertension. So it's either at home, as a patient we give him a machine, or we do it in our clinics. So when we diagnosed hypertension, for all patients with a new diagnosis of hypertension, we need to do blood tests. We need to measure the creatinine, we need to measure the electrolytes, we need to do an electrocardiogram, and we need to do an echocardiogram to see when we see signs of the ECGs at the heart, signs of complication of the ECGs, then we have to do an echocardiogram. to check for muscular hypertrophy on the heart due to high blood pressure, and to check for aortic valve disease or other complications related to high blood pressure. So for grade 1 hypertension, we need to start treating patients when we are in the grade 1 hypertension. Grade 1 hypertension, as we said here, it's a blood pressure between 140 to 159 systolic. So when we have a blood pressure in this range, we need to initiate treatment. We need to initiate, we can start by either one drug or a combination of two drugs. It's a class 1 recommendation to treat patients when they are in the grade 1 hypertension range. So now the target of blood pressure in patient age 18 to 69 should be between 120 to 130 millimeter mercury systolic. And for patients that are above 70 years of age, here we can have, we can tolerate blood pressure a bit higher, but we need to encourage patient, even that old patient, to have a blood pressure of less than 140. And if we can reach 130, it's also adequate. And we have to know that for all conditions and all age groups, we need to target a diastolic blood pressure of less than 80 millimeter mercury. Diastolic blood pressure is as harmful as a systolic blood pressure. So we need to also try to reduce diastolic blood pressure to less than 80 for all patients and all categories. So how to do this, how to reduce the blood pressure? First of all, we need to do lifestyle intervention for all patients that have an elevated blood pressure. So we need to do this for everyone, not just give medications. Lifestyle intervention for diet and exercise is very important. We also need to start the treatment. We usually start by a 2-drug combination therapy in most patients. Studies have showed that starting 2 drugs at the same time in the beginning is better than starting 1 drug alone. So as we said, we need to do combination therapy. And what drugs can we give? We can give angiotensin receptor and ACE inhibitors or angiotensin receptor blockers, which this receptor acts on the level of the kidney regulation and will reduce blood pressure, and they have a long duration of action. And in association with a calcium channel blocker. Calcium channel blocker, as you know, in the hospital we use amlodipine or lercadipine. It's a calcium channel blocker that is a vasodilator. It will vasodilate the vessels. Or we can use also a diuretic. Diuretic will decrease the volume in the system. So when you decrease the volume, automatically the blood pressure will drop. So we need to use a combination of ACE inhibitor or ARBs with either a calcium channel blocker or a diuretic in the beginning for all patients. If the blood pressure remains uncontrolled, we then need to use a 3rd drug. So we need to use 3 drugs at the same time. And now we have drugs, a single pill containing 2 drugs or 3 drugs at the same time. So it's a lot easier for patients and for compliance. So patient now is less likely to skip a medication because all the drugs are in a single pill. So it's very important. If the blood pressure is not controlled by all these 3 drugs that we mentioned, we need to use a 4th drug, which is a mineralocorticoid receptor antagonist, which is a spironolactone, which is also will act on the renin-angiotensin-aldosterone system, and it has a very efficacy on reducing blood pressure. But we need to be very careful with this drug because it can increase the potassium level and it can cause renal injuries. So we have to do routine blood tests for this drug. So it's very important to ask the patient to sit for 5 minutes before taking his blood pressure in a quiet place. And we need to do 2 measurements, 1 to 2 minutes apart, in order to confirm hypertension. And if we find that the difference between the 2 measurements is more than 10 millimeter mercury, we need, in this case, to do a third blood pressure measurement to confirm. So as we said, for all patients with hypertension, we need to do all this workup. We need to measure the creatinine. It's very important. We need to do an electrocardiogram. We need to do an urine analysis to look for proteinuria, because proteinuria as well, when you see proteinuria with hypertension, it means that the patient had hypertension since a long time, more than 10 years, we can confirm. And when we find hypertension in young patients, for example, in patients less than 40, in that case, we need to look for secondary causes of of hypertension. And we have a lot of causes of hypertension, like, for example, renal artery stenosis. When you have renal artery stenosis, we had a high, this will induce, will have a high risk of high blood pressure, especially in young patients. And we have a disease called pheochromocytoma. This disease will have a lot of norepinephrine and epinephrine secretion. It's associated with headaches, with tachycardias, and with episodic high blood pressure. So we need to look for all these conditions when we find a high blood pressure in a young patient. Obstructive sleep apnea is as well a common cause of high blood pressure in young individuals, especially obese patients. So we need also to send the patient with hypertension that is young to a sleep pulmonary doctor specialist in order to try to diagnose obstructive sleep apnea in these patients. So as we said, the target ranges of blood pressure for patients between 18 and 69 should be 120 to 130 systolic and less than 80 diastolic. And in all conditions, in diabetes, in CAD, coronary artery disease, in stroke, it's the same for everyone. In CKD, we can tend to maintain a bit higher blood pressure for patients to avoid hypotension, because hypotension in patients with CKD is not good. And for patients above 70 years of age, as we said, we can be less aggressive with the blood pressure lowering, so we can tolerate blood pressure of 140 millimeter mercury. But it's better to have a blood pressure of 130 even for older individuals. Okay, so this picture is a summary for everything we said on high blood pressure. So we need to start the first initial pill, which is a combination pill that should contain two drugs: an ACE inhibitor or an angiotensin receptor blocker with a calcium channel blocker or a diuretic. If the patient have uncontrolled blood pressure, then we need to use the triple combination therapy. So either an ACE or an ARB plus CCB plus a diuretic. And if the patient remained uncontrolled, then we need to add the spironolactone drug. We said the patient will end up with 4 drugs, but we can have one pill containing 3 drugs, for example, so the patient will be more compliant with his treatment. So as for diabetes mellitus now, we move to diabetes. It's very important to encourage lifestyle changes, and we need to try to reduce energy intake in order to lose weight and improve blood glucose levels. So weight loss is very important, and it's very encouraged to try to drop the hemoglobin A1C, which is the average of glucose level in the last 3 months in diabetic patient, to less than 7%. Okay, so how can we treat diabetes? We have metformin, which is the gold standard medication. We use it for almost all patients as a first option to treat diabetes. It's very good drug, but we need to be very careful with this drug, especially for patients with renal dysfunction, because it can cause lactic acidosis and it can cause kidney injury. So we need to be very careful with kidney disease. And as a second line, or now it's used as a first line, we said before the SGLT2 receptor inhibitor. This drug is a new drug. It's called Forxiga. Its commercial name is Forxiga, dapagliflozin, and it's very used nowadays for diabetes. This drug is very helpful because it also acts on the heart. So patients with heart failure will benefit a lot. We'll have 30% mortality benefit for patients with heart failure when we use these drugs, even if patients that are not diabetic. So this drug is helpful for diabetes and for heart failure at the same time. And it's very helpful as well in patients with diabetes and chronic kidney disease, because this drug was found to improve diabetes and to improve the progression of chronic kidney disease. So we need to use it as a first line nowadays for diabetic patients. We should use it with metformin as a first line. As we said, it's very good with heart failure with reduced ejection fraction, meaning that patients with an ejection fraction, when you do an echo, we found an ejection fraction of less than 35. And in recent studies, it was found to be effective for patients with preserved ejection fraction as well, with heart failure. So now for aspirin. Aspirin is recommended for the secondary prevention of cardiovascular disease. So if a patient is already have an established coronary artery disease, aspirin is a class 1 recommendation. We can't tolerate the patient with coronary artery disease not to be on aspirin. And clopidogrel is sometimes as a second antiplatelet agent, is sometimes an alternative to aspirin use if a patient can't tolerate aspirin or if a patient is allergic to aspirin. And it's very important to use proton pump inhibitor like omeprazole or pantoprazole in patients that are on antiplatelet therapy and have high risk of gastrointestinal bleeding. High risk of gastrointestinal bleedings are patients with old age or patients with a history of gastrointestinal bleeding. So it's very important to add the proton pump inhibitor to this patient to avoid a bleeding complication, but not for everyone. Not everyone that is on aspirin should be on a proton pump inhibitor. And that is very wrong. You usually see a lot of patients on aspirin and on proton pump inhibitor without a reason. So we have to avoid this. Okay. So it's very important also. So when a patient is hospitalized, for example, for a cardiac disease, for heart failure, for myocardial infarction, it's very important to insist on cardiac rehabilitation. In many countries, we have a lot of cardiac rehabilitation centers, meaning that after the duration of hospitalization, we send the patient to this center in order to educate him, to initiate the treatment, to monitor all the side effects of the treatment. So it's very important to encourage cardiac rehabilitation, which is sometimes not very used in many hospitals, but we need to focus on this area of medicine. So aspirin, as we said, is recommended for patients with a previous myocardial infarction or any patient with coronary artery disease with a stent or with revascularization. We need to put him on aspirin. And when a patient developed acute coronary syndrome is a myocardial infarction, ST elevation myocardial infarction or non-ST elevation myocardial infarction, we need to use combination antiplatelet therapy. So aspirin plus clopidogrel or aspirin plus ticagrelor, which is Brilinta, and we need to use the combination of these drugs for 12 months. Then after that, we can stop one of the two drugs and keep the patient on just aspirin. So it's very important to use the combination drugs, and we need to know as well that beta blockers, which are bisoprolol, most commonly used in hospitals, it is very important to use it in patients with LV dysfunction, so in drop in ejection fraction and heart failure, because we found that treating patients with heart failure with beta blocker improves mortality. Beta blocker will reduce the heart rate, so will decrease the myocardial contraction and will decrease the oxygen demand by the heart, and this will improve outcomes on a later term. And we need to use ACE inhibitor or ARB in patients with heart failure as well, because this drug was found to have a reduction of 25% mortality in patients with heart failure. And we need to use lipid-lowering agent, as we said, efficacy for all patients with acute coronary syndrome and coronary artery disease, and to target an LDL level of less than 55, or a 50% reduction from baseline, meaning that if a patient has an LDL of 200, it's very hard to drop it to less than 55. And this patient, we need to, as a first step, target a reduction of 50%, to drop it from 200 to 100, for example. And at a later stage, we can increase the dose of the statin medication, and we can reach levels of less than 55. So that's it concerning this topic. If you have any questions, I'm ready to answer.
Thank you, Dr. Antoine.
Okay.
Can we move to the second piece before taking a 10 to 15 minutes break?
Yes, I will share the second one. 1 minute.
Yes. So it will be the dietary therapy and prevention of cardiovascular disease.
Yes. Can you see the slides, Dr. Eli?
Yes, yes.
Okay. So we'll move to the second topic, which is dietary therapy and prevention of cardiovascular disease. So the objective of this webinar, we have a lot of objectives. We need to explain the two scientific causes of cardiovascular diseases, identify the lifestyle changes that needed to prevent cardiovascular disease by implementing a healthy diet. So, so as you know, 1/3 of all deaths in the world is attributed to heart disease and to stroke. So 1/3 of deaths worldwide is due to cardiovascular disease. And this data is from the last 25 years. So cardiovascular disease is a major cause of death nowadays. So you can see here the cause of death in perspective. You can see in yellow the heart and the circulatory disorder. It's a major cause of death. It's even more important than cancer and then respiratory disorders. So we need to try to target this population in order to reduce mortality and to reduce hospitalization and reduce cost of hospitalization. So it's very important to focus on diet in order to treat the heart and circulatory disorders. So as we said, cardiovascular diseases account for nearly around 1 million deaths in the US each year. So every 1 to 3 deaths in the US are attributed to cardiac disease. And every day, 2,300 Americans will die from cardiovascular disease. And average 1 death every 30 seconds will be due to cardiovascular disease. And around 92 million American adults are living with any form of cardiovascular disease. So hypertension, heart failure, coronary artery disease. And you can see that the cost of cardiovascular disease is very, very important. $329 billion each year are used to treat cardiovascular diseases. So it's very important to try to prevent cardiovascular disease in order to reduce cost. So cardiovascular disease is related to age, to high age. It's more common in males, especially less than 50, but above 50 and after menopause, it's the same between males and females. We have a lot of genetic and family history. We have cholesterol level will influence cardiovascular disease, high blood pressure, type 2 diabetes, obesity, smoking, and all the risk factors we discussed in the first presentation. One of the major causes of cardiovascular death is atherosclerosis. Atherosclerosis is the accumulation of lipid molecules in the blood vessel lumen and wall. So as you can see in the image, we have narrowing of the blood vessel due to accumulation of cholesterol plaques. And this will lead to complete vessel obstruction and to myocardial infarction. And all this is influenced directly by diet. Diet is a primary focus on prevention cardiovascular diseases. So as we said, cholesterol, you can see here is the HDL and the LDL molecules, which will deposit in the blood wall, as blood vessel wall, and will decrease the blood vessel diameter and cause a complete obstruction of the vessel when the plaque ruptures. So we have a myocardial infarction and reduction of blood flow to the myocardium. Hypertension, as we said, the hypertension as well is you can see is on the slide is in vasoconstriction of the blood vessel. And for example, it's a lot related to diet. For example, if we have a lot of salt intake, it's very associated with the high blood pressure. And if we have a lot of fatty foods, it will make the vessel wall more rigid, so it will increase the blood pressure significantly. Moving now to type 2 diabetes, which is also very related to diets. Cardiovascular risks, including obesity, hypertension, dyslipidemia, are common. So it's very common to have a patient with diabetes and with obesity, with hypertension, and with dyslipidemia and other cardiovascular diseases. So it's very important also to implement a diet that can target patients with type 2 diabetes in order to reduce the blood glucose level, in order to better improve diabetes outcomes and cardiovascular disease outcomes later on. So as you can see here on the slides, it shows here the BMI, which is the body mass index, and the relation of BMI and the risk of developing cardiovascular disease and cardiovascular mortality. You can see that for patients with a BMI of 32 is associated with the highest increase in cardiovascular disease and cardiovascular mortality of 5.8%, which is a lot higher than patients that have, for example, a BMI between 22 to 24. We will have here you will have here just a 1% risk. So we need to try to reduce the BMI significantly with diet. So moderate weight loss, even of as little as 10% of weight loss, will improve and prevent obesity-related factors for cardiovascular disease. So diet is very important for weight loss. Physical inactivity as well, which is in part related to diet, because many patients that are physically inactive tend to eat fast food, tend to eat unhealthy diets. So physical inactivity and associated with a bad diet will increase the risk also of cardiovascular disease in the future. Stress as well is linked to diet, and do you have a question concerning migraine and cardiovascular disease, Dr. Eli? I'm not seeing the questions. I'm not receiving the questions.
Yeah, I think Rawan Al-Muhammadi
Yes.
asked what relation between migraine and cardiovascular disease.
Yes. So the relation between migraine and cardiovascular disease is not very established, but we found in multiple studies that the risk of developing cardiovascular disease in migraine is increased, but we don't know exactly the mechanism behind it. We have a lot of theories, but we don't have a confirmation yet, and it's not very. It's in the guidelines now to, when you have a patient with migraine, to look for cardiovascular diseases. It's in the guidelines as a class 2A recommendation, but it's not, the relation between both entities is not very well established. Okay. So now moving to another slide. So we have the lecithin and the carnitine, which is these two molecules are found in many dietary meals like eggs, milk, cream, dairy, liver, red meat. So it's found in unhealthy, if you want, unhealthy meals. So when lecithin and carnitine go to the gut, in the gut, we have bacteria that secrete TMA, which is an enzyme, which will convert the lecithin and the carnitine to TMAO. And this molecule will increase the risk of vascular disease. In patients that are vegetarian, so vegetarian will not have ingestion of lecithin and carnitine from the food. So these patients will not have these molecules and these enzymes. So they will have very less risk of developing cardiovascular diseases later on, because they don't have lecithin and carnitine in their diet. So the gut bacteria will not secrete the TMA, so will not have vascular molecule deposition. So vegetarians are better in case of vascular diseases. A study done in Harvard School called Red Meat Increases Risk of Premature Death. At this study, we had around 120,000 patients, and they followed them for around 28 years. And they found out that the risk of dying is up to 12% with daily red meat. So if we eat daily red meat, we had increased risk of deaths by 12%. And if we eat other type of products like hot dogs, ham, or bacon, we have increased risk of death by 20%. So diet is very important. And this study concluded that the foods that should be included to prevent cardiovascular disease are grains, legumes, lentils, and vegetables, and fruit, which have health benefits. Okay. So we have a second study called monochemical synthesis study, which is in this study they asked stopped all fat food for patients for around 90 days, and they found that after 90 days, patients will not crave fat anymore. So they will not ask for fat anymore, because the receptor responsible for fat craving in the brain will be downregulated. So if we succeeded to remove fat from or to reduce fat a lot from a diet for 90 days, patients that were on a fat diet will stop craving fat after 90 days. And this was very helpful in reducing cardiovascular disease. As you can see, the average mean cholesterol for patients participating in the study was 237 milligram per deciliter. And after stopping fat for years, they reduced the cholesterol level from 250 to 130, and the LDL level also was reduced to a normal range of 76. So eliminating fat from a diet is very helpful to improving the cholesterol number and the LDL numbers. Another important point is this is a coronary angiography. This is a coronary artery. It's a coronary artery of a patient. As you can see on the first slide, I don't know if you can see my pointer, but you can see in the image on the left, we have a narrowing of the vessel lumen. So here we have the position of lipids and cholesterol and atherosclerosis in the vessel lumen. In this study, after years of diet improvement and fat reduction, they found that the vessel lumen increased in size once more and blood flow was regained. So diet can help reverse atherosclerotic cardiovascular disease. Not only medications or surgeries or interventions, invasive interventions. We need to focus on diet as a first-line treatment in order to try to reverse the atherosclerosis and the cholesterol deposits in the vessel walls. And here it was very effective, and it's a real case study. Here is another example. This is the left circumflex coronary artery on the heart. You can see we have a narrowing of around 60 to 70% of the artery on the left image. And after implementing a very healthy diet, you can see that the narrowing of the vessel was reversed, and we had a normal vessel diameter after initiating the adequate diet. Here is another case also of a right coronary artery vessel. You can see a narrowing of significant narrowing of around 70 to 80% of the mid right coronary artery on the left image. And you can see after implementing diet, we had reversal of the atherosclerosis and reversal of the plaques on the vessel. So we have an opening inside the vessels. Here is a third example, fourth example of a patient with a distal LAD. This is the left anterior descending, which is the most important artery of the heart, coronary artery of the heart. You can see that after diet, we had also a reversal of the atherosclerosis and atherosclerosis process, and we have a vessel that is well functioning after implementing an aggressive diet modification for patients. Here is a myocardial scintigraphy for patients. So this is a nuclear test. This is the heart. You can see the heart here. So when you see a when you see a green or a green color, meaning that we have a hypoperfusion. We don't have a very well perfused myocardium from vessels. So we have surely a coronary artery disease as well. So after implementing aggressive lipid lowering strategy by reducing cholesterol by diet, 10 to 14 days later after that, you can see we repeated the exam, we repeated the myocardial scintigraphy, and you can see now yellow and orange color. Yellow and orange color means that it's normal. We have an adequate myocardial perfusion. So here we proved as well that diet can reverse coronary artery disease effectively. Okay. So here is another example as well for a patient with a baseline cholesterol level of 248 on the left. He had a poor perfusion on the scintigraphy, and after aggressively lowering his blood cholesterol, you can see that we have homogeneous coloration and homogeneous uptake of the myocardium in the after the treatment. So it's a reversal of the atherosclerosis as well. Here is a patient that had a left main. So left main is the main coronary vessel of the heart. You can see that we have a significant narrowing of the distal left main coronary artery. So this patient had angina symptoms, has chest pain on exertion, and after treating him and after changing completely his diet, the patient had this lesion because it was a calcified lesion. So it didn't disappear, but his symptoms has improved significantly because we stopped the disease, we stopped the plaque and the narrowing progression in these coronaries. So we had a reversal of symptoms in that case. Here is an image illustrating the atherosclerosis formation. You can see that it proves that we have a reversal of the plaque diameter, and we have increase in the diameter of the vessel with diet. Another trial, which is a trial that had a period of 12 years analysis, and in this trial, they didn't have a lot of patients in this trial. It's a US-based trial, but they found out that patients that did not follow the recommended diets by the primary investigator of the trial. We had 6 patients that didn't follow the recommendations, and in these 6 patients, they had 30 new cardiac events. They had increasing angina, they had ventricular tachycardia, they had bypass surgery to try to reduce the weight, they had a coronary stent angioplasty, they had heart failure, and they have one of the 6 patients had a death from arrhythmia. So in all these 6 patients, we have 13 new cardiac events and on average 2 events per patient. So we didn't have a reversal of cardiovascular disease because they didn't follow the implanted diet by the primary investigators 12 years later. So they had a lot of the cardiovascular diseases 12 years later after starting the trial. While the other patients, for example, we had a lot of, we have 18 other patients. These 18 other patients, before starting the trial, they had cardiac diseases. They had angina, they had myocardial infarctions, they had strokes. They had coronary vascularization by stents because of myocardial infarction. So after implementing the adequate diet, so after implementing the adequate diet, they had no cardiac complication for the next 12 years. So they had a lot of cardiac complications 8 years before starting the study. But when we started this, they started this study and they implemented an aggressive diet modifications. They found out that these patients have no cardiovascular disease in all patients that were compliant to the diet, as opposed to the patients that were not compliant to the diet that had a lot of cardiovascular issues. So another study, which was called the Healthy Diet and the Risk of CVD Among Patients on Drug Therapies for Secondary Prevention. This study incorporated 31,546 participants, and all these participants had aggressive diet modifications, and they found out that from these patients, we have, as compared to patients without cardiovascular, as compared to patients that are not on the adequate diet, we have in patients with adequate diet, there was 35% reduction of deaths, 14% reduction of myocardial infarction, and 19% reduction in stroke. So it's very, very important to use diet in order to reverse the cardiac complication and not just use medications without trying to modify the diet. In Finland, for example, as you can see here, in Finland, back in the years in the 60s and 70s and 80s, they had a lot of cardiovascular disease. It was the country maybe with the most cardiovascular disease mortality in the world. But when they started implementing an aggressive diet modifications in the 1978 and 1980 years, we can see that the curve started to drop and the mortality dropped a lot, reaching around 100 per 100,000 deaths. So it's very, very good and one of the best numbers in the world in Finland. And after that, many countries adopted the same strategies that Finland used, and we can see a lot of European countries with very low cardiovascular mortality, and increase in average age of the population by implementing healthy diets. So another study, which was called the risk of hospitalization or death from ischemic heart disease among British vegetarians and non-vegetarians. So here in UK, they had two groups: a group of vegetarians and a second group that were not vegetarians. And they found that vegetarians experience weight loss, so experience a decrease in their body mass index, a decrease in their blood pressure, a significant decrease in cholesterol, and a significant decrease in ischemic heart disease of 32%, which is a huge number to try to reduce the ischemic heart disease by 32% just by using the vegetarian diet. So it's a very big study, and we had a very big sample size. So it's very and it's very true. So the numbers we found in this study can't be applied to the daily practice. Another study done in the US, it was called Treating the Cause, which was done over 3.7 years. It included 200 patients. Between these 200 patients, we had 177 patients that were adherent to the diet. So 89 of these were adherent, and 21 patients were non-adherent to the diet. And we had 2 patients that lost follow-up. So all these patients had the diagnostic test to look for coronary artery disease, like coronary angiography or CT angiography or stress test. And all these patients had hyperlipidemia. 161 patients from these had hyperlipidemia, 60 had hypertension, 23 had diabetes, and 44 had prior myocardial infarction. So all these patients were cardiac patients, so established cardiac patients, and they tried to change their diets. And between the 177 compliant patients, we found that 144 patients from these 177 had improved outcome and have decreased mortality from cardiovascular disease, and 39% had reversal of their disease. So when they did the repeat coronary angiogram to view the vessels, they noticed a regression of the plaque and the atherosclerosis formation in the vessels in 39 patients from the 177, which is also a huge number. And 15 patients remained stable, so they did not progress in their disease. Only one patient had a stroke, and one patient had a surgery to treat his coronaries, a coronary artery bypass graft surgery. Just 2 patients from the 177 had disease progression, and 5 from these 177 had deaths, but the death was attributed to unknown cardiac cause. I think 4 from these deaths were attributed to cancer, which is not related to their cardiovascular disease initially. So here they found that diet was very, very effective by treating the cause, and it is very, very effective. So from the patients that were not adherent, we said that we have 21 patients that were not adherent to the diet that was implemented initially. 0 from these 21 patients improved, just 8 remained stable, but the majority had disease progression and disease worsening. So 11 patients had stroke, stents, coronary artery bypass graft, and arterectomy to treat the carotid vessel, and 1 had heart transplant, and we had 2 deaths, and the 2 deaths were attributed to cardiac deaths. So here it's very different. It's very significant. It's significant, and it's very clear that patients that were not adherent to diet and were adherent to a fatty diet or fast food diet had a lot of complication and a lot of progression in their disease. So as you to resume, to make a summary, just we have for patients that were adherent to the diet, just 1% had recurrent events. And for patients that were not adherent to diet, we had recurrent cardiovascular events in 62% of cases. So it's a very, very big difference. Okay. So now if we can, this study, the last study that we discussed, the treating the cause study, the last one that we discussed, as you can see, because in this study they treated the cause, they used a very, very aggressive diet, they eliminated fat, they reduced fat a lot from the diet. We can see as compared to other trials, which is the COURAGE trial, the Lyon Diet Heart study, we can see that the in this study we had a lot of reduction in the cardiovascular events as compared to different studies, because here they were more aggressive in the diet modification, and they tried to treat the cause by using a specific diet for specific diseases. So, we can say that even if we use a healthy diet, for sure, a healthy diet will not die from the diet, because it's a healthy diet, so we'll not have a mortality from it, and for sure will have benefit over time. So there is no harm in changing the diet or using a healthy diet. And sometimes patients that have advanced disease, sometimes they are very motivated to change the diet, because when they change the diet, they have the feeling that they are empowered by the knowledge that they are in control of the disease. So they think they can reverse the disease. So we need to motivate the patient in order to change their lifestyles. So now I will try to go into the details of each type of diets. We have the saturated fatty acids. So when we have which is the most hyperkalemic fats, it's this type of diet is associated with cardiovascular disease progression. We can find this saturated fat in milk, cheese, butter, bakery goods, and fast food and snacks. And you can see that the 11% the average American intake is 11% of saturated of kilocalories. So they use a lot of saturated fatty acids. That's why they have a lot of cardiovascular diseases. So we need to avoid these saturated fats. We have the low-fat diets. So the low-fat diets, diets that comprise of 25 to 35% of fat, and it's an alternative. It's an alternative to the typical Western diet, and generally this diet will use more carbohydrate intake in order to compensate for the energy loss by reducing fat. So we'll have an increase in the carbohydrate intake by using low fat diets. Sorry. We have a lifestyle called the TLC, the therapeutic lifestyle change. The therapeutic lifestyle change is not only a diet, it's a lifestyle. So TLC is based on alimentary regime that aims at reducing the cholesterol intake. It's not just a diet, but it's a long-term nutrition style which enhances the quality of life. So it's a diet, it's exercise, training, it's smoking cessation. It's a combination of multiple factors in order to improve the quality of life. And you can see that the TLC diet contains saturated fat should be less than 7% of total calories, polyunsaturated fat up to 10%, monounsaturated fat up to 20%, and total fat from 25 to 35%. But we have carbohydrates, 50 to 60% of total calories, fibers, we need to use 20 to 30 grams a day, and we need to use 15% of our total calories to be proteins, and we need to minimize the cholesterol to less than 200 milligram per day with this type of diet. And in this type of diet, we need to use breads and cereals for more than 6 servings per day, and we need to use more vegetables, and use dairy products 2 to 3 servings per day, eggs less than twice per week, and use fish, as we said in the first presentation, once or twice per week. And we can have fat and oils. We need to adjust to the caloric level. So we need to eat more of this food. We need to eat more vegetables. We need to eat more low-fat milk, unsaturated oils. We need to decrease red meat, and we need to increase the grain and cereals in our diet. So now we move to the DASH diet. The DASH diet was meaning that DASH mean dietary approaches to stop hypertension was first used in order to try to treat hypertension. It's a diet that is recommended by the AHA, which is the American Heart Association. This diet includes vegetables, fruits, low-fat dairy, whole grains, chicken, nuts, and fish. Oh, and it's a diet that is low in sugar and saturated fat and meat and sodium. So it's a diet targeted initially for hypertension, which is low in sodium, low in sugar, low in fat, and it contains a lot of vegetables and grains and healthy food. So they found that with this diet, we had a reduction in both systolic and diastolic blood pressure in both in hypertensive and in normotensive individual. For example, if a patient has a blood pressure of 115, which is normal, they had also a reduction of blood pressure between 5 to 10 millimeter mercury. So they dropped to 95 or to 100. And patients with hypertension had also a reduction in blood pressure by using this type of DASH diet. So you can see here in this image, we need to have grains of 6 to 8 servings per day, fruits and vegetables 4 to 5 serving per day, low-fat dairy 2 to 3 serving per day, and we need to limit fats and sweets, and we need to use nuts 4 to 5 serving per week, and we need to use protein with 6 or less serving per day. So the most important part here is to try to divide the portions to multiple times a day, not just eat everything at the same time. We need to encourage patient to try to more organize his diet, and here we need to ask for the help of diet specialist or dietitians. Moving now to the Mediterranean diet, a lot of Middle Eastern countries and Arab countries use this type of diet. This diet is characterized by a relatively high fat intake, so it contains a bit high of fat, but not just the bad type of fat. And it's also based on the intake of fresh fruit, vegetables, whole grains, legumes, nuts, and olive oil. Olive oil is very essential in the Mediterranean diet. And they found that adherence to this type of diet was associated with decreased risk of cardiovascular events by reducing triglyceride levels and by increasing the HDL-C level and by improving insulin sensitivity. So also this diet was effective in reducing lipids and improving diabetes mellitus, and by doing this we decrease cardiovascular events on the long term. So we need, as we said, to increase whole grains and diet fiber, vegetables, fruit, nuts, milk, and dairy products. We need to alcohol use it. We need to encourage patient to stop alcohol, or as a patient can't stop it, we need to encourage him to reduce it to 1 to 2 per day. We'll discuss this later in the slide, and we will discuss coffee, tea, chocolate, and in later slide as well. So now we move to the whole grains and dietary fibers. So when we use this, when we increase grains and dietary fibers in our diet, this type of diet was associated with lowered total cholesterol. So we can drop cholesterol by 7.7 milligram per deciliter, and we can drop LDL by 6.9 milligram per deciliter. It's not a lot, but when we use it in association with medications, we'll have a more prominent drop in cholesterol level. So it's very important to use these types of food. And the current guidelines recommend a daily dietary fiber intake of 25 grams a day. So it's very important to eat 25 grams a day for an adult woman and 38 grams for another adult man. And this is according to the American Heart Association studies. So this type of diet will help by reducing the cholesterol, and by reducing the cholesterol, we reduce the atherosclerosis and the cardiovascular mortality on the long term. Now moving to vegetables and fruits. Why vegetables and fruit are effective? Because they found in multiple studies that vegetables and fruit reduced cardiovascular disease by 7%. And they lowered blood pressure they lowered blood pressure, and it's recommended to use multiple servings of fruit and vegetable per day because it contains a high antioxidant content. High antioxidant content will decrease platelet aggregation, will decrease coronary artery disease, even will decrease a lot of other diseases other than the cardiovascular diseases. So you can see here on this image, on the left one is when we eat 400 calories of oil, it's just a very small quantity of oil will give us a lot of calories. So it's bad. It's bad. Just a small volume of oil will give us 400 calories. While 400 calories of chickens, you can see the volume here on the stomach. While if we eat all these vegetables, we will just gain 400 calories. So we will have less calories, less weight gain, and we'll have a lot of health benefits, and we'll have satiety. So when we eat a lot of vegetables, patients will not require to eat other forms of calories if we implement this diet on the long term. Patients will be used to eating healthy. So now moving to nuts. Nuts are also very essential because we found out that high nut intake was associated with 35% risk of reduction of cardiovascular disease in a study published in 2008. And the LDL concentration was reduced by a mean of 10.2, and the triglyceride were reduced by 20.6 milligram per deciliter, which is not bad at all. And it helps the medication, and we can combine the nuts with medications in order to have a better reduction of lipids. And it's recommended to consume around 20 to 30 grams of unsalted nuts per day. So we need to make sure there's no high quantity of salt in this in the nuts, because as you know, salt is associated with elevated numbers of blood pressure measurings. Now moving to milk and dairy products, you can see that milk we have a modest inverse association between milk and cardiovascular disease, but it was not very significant. It was not associated with benefit or harm on the cardiovascular disease, but it was associated with it was found to be milk products like it can contain the bacterial lactobacillus. It was associated with lower blood pressure. So we don't have a real mechanism to explain why milk reduced blood pressure, but it was just a statistically significant reduction in blood pressure for patients that consume more milk products, and as compared to patients that used unhealthy products. As for alcohol, moderate alcohol intake, 1 to 2 drinks a day, is associated with a reduced risk of cardiovascular disease, but the mechanism of this is by increasing HDL and by decreased platelet aggregation. So decreased platelet aggregation meaning decreased plaque formation, meaning decreased atherosclerosis, we mean by this decrease in coronary artery disease. But even with this benefit, we need to encourage patients to stop alcohol, especially patients with cardiovascular diseases, because when patients start with 1 to 2 drinks per day, they might be dependent after that on alcohol, and they can increase their alcohol consumption, especially if faced to stressful events or to any life-changing events. So it's not recommended to encourage patients to consume alcohol. As for coffee, we have 80 to 90% of adults that report that they consume coffee on a daily basis. Coffee has antioxidant properties, it's a cardioprotective, meaning it protects from CAD, coronary artery disease, and it has a modest evidence, so it's not a lot effective to prevent coronary artery disease. And also it has a risk of developing type 2 diabetes in individuals that consume more than 4 cups a day versus individuals that consume less than 2 cups a day. So it increases the risk of developing type 2 diabetes, but it has some benefits, especially if used if we don't use a lot, less than 2 cups a day. Now moving to tea, we have 2 types of tea. We have the green tea and we have the black tea. We found out that green tea is decreased risk of coronary artery disease incidence in a study published in 2001 as compared to black tea. Black tea was not found to be effective in reducing coronary artery disease. Green tea was also found to be effective in lowering the risk of ischemic stroke if we consume less than 1 cup a day. But green tea did not affect the blood pressure and did not reduce the LDL level. So it was found that it decreased the risk of CAD incidents, but it was not related to reducing blood pressure or reducing LDL-C level. Maybe it has antioxidant effects. It decreased platelet activation. We don't exactly know the mechanism, but it has benefits, especially the green tea. So it's recommended to, if our patient asks us, we need to recommend him to use green tea, not as a black tea. As for chocolate consumption is associated with lower risk of cardiovascular disease, mainly if it's used in small portions, not if used in a lot, because it can increase diabetes mellitus, uncontrolled blood sugar. But however, we should not recommend it. So as we said for alcohol, we should not encourage our patient to consume chocolate to prevent coronary cardiovascular disease. It's not recommended. But in some studies, it showed cardiovascular risk reduction, but we should not recommend it to our patients. And if we need to give advice, we need to say that dark chocolate has a higher percentage of antioxidants, and it's the preferred type of chocolate. So we need to tell the patient that dark chocolate is better than other types of milk chocolate, for example, of white chocolate. Now we move to garlic. Garlic is a very essential ingredient to many foods we use. So it was found to reduce the total cholesterol, but it has no effect on the HDL. The HDL is the good cholesterol, as we know. It has no effect on the LDL, but it reduces the total cholesterol and it reduces the LDL level, and it decreases platelet activation. So we had decrease in long term. We had favorable cardiovascular effects on the long term. So it's recommended to eat 2 garlic cloves per day in order to try to reduce blood cholesterol, especially in patients with high cholesterol level, in order to help with the medication to achieve better reduction in blood cholesterol. But here we are talking about the garlic that is not deactivated by heat. So when we put heat to the garlic, the garlic will lose a lot of cholesterol reducing power. So it has to be not exposed to a lot of heat. Now moving to omega-3. Omega-3 consumption, as you know, is found in fish oils and fish products, and it has a tendency to lower cholesterol, LDL, and triglyceride, and reduce sudden cardiac death. It's effective in reducing sudden cardiac death. And one fatty fish meal per week resulted in 50% decrease in risk of cardiac arrest. So it's a huge number. So we need to add fish meal to our patients, especially our patients with established cardiac disease, to prevent cardiac arrests for them. And if we can't add fish to the diet, we can supplement patients with 1 gram of omega-3, which is like a tablet or a medication, which also was associated with reduction of cardiovascular disease and non-fatal myocardial infarction and non-fatal strokes. So we had a lot of benefits with omega-3 implemented in the diet. Now moving to eggs. Most studies, large studies done on the diet rich in eggs, there was no association between eggs consumption and cardiovascular disease. But we can tell the patient that if we consume eggs, we will not increase our cardiovascular disease. So it's like a neutral. It's like a neutral relation. But in patients with diabetes and heart disease and hypercholesterolemia, we should tell the patient to not to limit egg consumption to 3 to 4 eggs per week, not more, because it can increase lipids, especially in patients with already established heart disease and dyslipidemia. Okay. So now I will move just a few slides about the guidelines of European Society of Cardiology guidelines on nutrition and alcohol. All of these are class 1, so they are recommended. So a healthy diet is recommended as a conclusion for cardiovascular prevention in all individuals. There is no exception. We need to force a healthy diet for all our cardiac patients. And it's recommended to adopt a Mediterranean or similar diet to lower the risk of cardiovascular disease. So the Mediterranean diet was incorporated in the European Society of Cardiology guidelines of 2021, the most recent guideline on this topic. And it's we have to replace saturated with unsaturated fat to lower the cardiovascular disease. And we have to reduce salt intake, as we said, to lower the blood pressure and reduce the risk of cardiovascular disease by lowering the blood pressure. And we need to use more plant-based food pattern, rich in fiber, rich in vegetables, rich in fruits, rich in grains to our diet in order to reduce the risk of death and cardiovascular disease. And we need to restrict alcohol consumption. It's very important to a maximum of 100 grams per week, not more, especially in patients with cardiovascular disease. And it's recommended to eat fish, as we said, once a week. And it's recommended to restrict free sugar consumption because free sugar consumption will increase the risk of diabetes. And as you know, diabetes is associated with a lot of complications, or cardiac complications and coronary artery disease as well. So a healthy diet will adopt more plant and less animal-based food patterns. So they encouraged here the vegetarian way of diet, containing less fat, and containing less than 5 grams of salt intake a day and containing 30 to 45 grams of fiber per day. Preferably it should be whole grain fibers and more than 200 grams per fruit and divided into more than 2 to 3 servings a day, and 200 grams of vegetables per day in 2 to 3 servings. So we need to divide each meal to multiple times per day. And red meat should be reduced to a maximum of 350 to 500 grams a week. Particularly processed meat should reduce it, and fish should be recommended 1 to 2 times a week, as we said. And we need to add nuts to the diet, 30 grams of nuts, which should be without salt. And as we said, alcohol should be reduced, sugar should be reduced, and red meat should be reduced, and fish should be increased. So this is the healthy diet characteristics. So now organizations and the ministries and a lot of countries are now using the economic initiatives in order to try to improve the diet. By using economics, meaning that we increase the price of unhealthy diet and we reduce the price of the healthy diets, and we impose taxes on food and beverages that are rich in sugar and rich in saturated fat and alcoholic beverages. So we need to put taxes on these foods in order to try to limit their use. So a lot of countries are now trying to use this strategy, and this strategy is very recommended by the European Society of Cardiology of 2021. So it's like Finland did. Finland did this way, and they had a very, very important reduction in cardiovascular mortality, especially in the recent years. And we need to encourage also schools and work sites and community in order to do campaigns and promote healthy diets in children, in workers, in all kinds of works. We need to try to push for this in order to improve cardiovascular diseases on the long term. And this is also a class 1 recommendation. So we need to do it. And if we didn't do this, we consider this as a harm for the population, not just for the individual, for the whole population. So we need to try to implement it in our culture, in our societies, in the schools, in universities, in workplaces, in all communities, in order to promote cardiovascular disease prevention. And if you're interested, you can find all these guidelines. You can find the ESC Pocket Guidelines, which is a book. You can order it from Amazon or from any other store. And there is an ESC Pocket Guidelines application. You can find it on the App Store or on the Google Play Store. It's available. And you can also download the PowerPoint guidelines from the European Society of Cardiology 2021. So it's available for everyone. It is very important, especially for all healthcare workers, not only doctors, for nurses, for dietitians, for all healthcare, because we need to try to implement the healthy diet for all our patients, regarding of our specialty. And that's it. Thank you.
Thank you, Dr. Antoine, for this instructive sessions.
If someone has a question, I am ready to answer. I think we finished 5 minutes earlier, so I think I can answer some questions if you want.
Yes, sure. Any question?
I just saw someone, Ragad Al-Sulami, asked if we can get the slides. Yes, for sure, I can send you the slides. I will put my email here, or just can. We'll find a way to send you the slides. For sure, I can send the slides.
Okay, thank you, Dr. Antoine.
Yeah.
Okay, we will have around 15 minutes of break, and we will come back for the third session with me, with Dr. Edi, about physical activity and primary prevention of cardiovascular disease. Okay, so 15 minutes break. Thank you. Thank you, thank you. Okay, this session we'll be speaking about physical activity and primary prevention of cardiovascular disease. So as you know, the most common cardiovascular disease is coronary artery disease, which can lead to chest pain, heart attack, and or stroke. So other cardiovascular disease include congestive heart failure, heart rhythm problems, congenital heart disease, endocarditis, etc. The risk of certain cardiovascular diseases may be increased by smoking, as Dr. Antoine said before, high blood pressure, high cholesterol, unhealthy diet, lack of exercises, and obesity. It's estimated around 200 million people are living with coronary heart disease. Globally, around 110 million men and 80 million women have coronary heart disease. For about the heart and circulatory disease, it goes around 1 in 3, estimated 34% in 2022. So 1 in 3 deaths globally, and that's 19 million deaths each year, on average of 50,000 people each day, or 1 death every almost 2 seconds. Globally, heart and circulatory disease killed an estimated 10.8 million men and 10.2 million women in 2022, as for British Heart Foundation. According to Hazazi and Wilson, In Saudi Arabia, cardiovascular diseases are the leading cause of non-communicable diseases, death, accounting for 37% of total death, followed by cancer at 10%, then diabetes at 3%, respiratory diseases at 3%, and finally, the non-communicable diseases at 20%. The best killer, or the biggest killer worldwide, for the it's like we will be talking about top five if you want. For the man, coronary heart disease 5 billion, woman 4.2, and the total is 9.1 million. So the coronary heart disease is 9.1 million for as a total. The stroke is the second one, 3.3 million for men. As per the woman, it's 3.2 million, and 6.6 million, the total of, if you want, death due to the stroke worldwide. The third one is COPD for men, and for women also is COPD, and the total also is COPD for 3.3 million. The fourth cause, it's lung cancer, 1.4 million for men, and for the woman, it's the lower respiratory infection. So it's not lung cancer, it's a lower respiratory infection. And also the total of the causes of that is the lower respiratory infection, 2.5 million. The fifth cause is lower respiratory infection, 1.3 million. For the woman, it's Alzheimer and dementia, and the total is for the lung cancer. As per the global risk factors for heart and circulatory diseases, so we will be talking about number and percentage. The high systolic blood pressure, 10 million, it's 54% as a risk factor. Dietary risk, poor diet, 6.9 million, 37%. High LDL cholesterol, so raised cholesterol, 4.4 million, 24%. High fasting plasma, diabetes, it's 3.8 million, so around 20%. Air pollution, also 3.5 million, 19%. High body mass index, obesity and excess weight, 3.2 million, 17%. As per the tobacco, cigarette smoking, secondhand smoke, etc., 3.2 million, 17%. Kidney dysfunction, 1.7 million, 9%. So, what is physical activity? So, as per the WHO defines physical activity as any bodily movement produced by skeletal muscles that requires energy expenditure. So the popular ways to be active include including like walking, cycling, wheeling, sports, active recreation and play, and can be done at any level of skill and for enjoyment by everybody. So regular physical activity, if you want, is proven to help and prevent and manage non-communicable disease, such as heart disease, stroke, diabetes, and several cancers. It also helps prevent hypertension, maintain healthy body weight, and can for sure improve mental health, quality of life, and well-being. As per the benefits and risk of physical activity and sedentary behaviors, regular physical activity can, as you see, improve muscle or muscular and cardiorespiratory fitness, improve bone and functional health, reduce the risk of hypertension, coronary heart disease, stroke, diabetes, various types of cancer, and depression. And also can reduce the risk of falls as well as hip or vertebral fractures, help maintain a healthy body weight. So regular physical activity, such as walking, cycling, wheeling, doing sports, or active recreation, provides significant benefits for health. Some physical activity is better than doing none. By becoming more active throughout the day in relatively simple ways, people can easily achieve the recommended activity levels. So physical activity is one of the leading risk factors for non-communicable diseases. Physical inactivity is one of the leading risk factors for non-communicable diseases mortality. People who are insufficiently active have a 20% to 30% increased risk of death compared to people who are sufficiently active. Okay. So I will speak about how much of physical activity is recommended for every range of age. For children and adolescents aged between 5 and 17 years, should do at least an average of 60 minutes per day of moderate to vigorous intensity, mostly aerobics, physical activity across the week. They also should incorporate vigorous intensity aerobics activity as well as those that strengthen muscle and bone at least 3 days a week. And should limit the amount of time spent being sedentary, particularly the amount of recreational screen time. So talking also about health benefits of physical activity for children, you have this figure here showing this health benefits of the physical activity for children. Academic performance, you can see here the academic performance, improve attention and memory for sure. It's also improve the brain health, reduces risk of depression. They also improve the muscle fitness, builds strong muscles and endurance. Also, it works on heart and lung health, improves blood pressure and aerobic fitness. As per the cardiometabolic health, helps maintain normal blood sugar levels. As per the long-term health, it reduces risk of several chronic diseases, including type 2 diabetes and obesity. Also, it works on bone strength, strengthening bones, and it works also on healthy weight, helps regulate body weight, and reduce body fat. So we are speaking always on how much of physical activity is recommended for adult aged between 18 and 74 years. Should do at least 150 to 300 minutes of moderate intensity aerobics physical activity, or at least 75 to 150 minutes, 150 minutes of vigorous intensity aerobic physical activity, or an equivalent combination of moderate and vigorous intensity activity throughout the week. And should also do muscle strengthening activities at moderate or greater intensity that involve all major muscle groups on 2 or more days a week. And these provide additional health benefits. So as you can see here, we have this figure about health benefits of physical activity for adults. We have the immediate and long-term. Immediate benefits adults, a single bout for moderate to vigorous physical activity provides immediate benefits for health. So first we have, it improves sleep quality. It's also reduces feeling of anxiety. It also reduces blood pressure. As per the long-term benefits, it works on brain health, reduces risk of developing dementia, including for sure Alzheimer's diseases, etc., and reduces risk of depression. Also, it works on heart health, lowers risk of heart disease, stroke, and type 2 diabetes. As per the cancer prevention, lowers risk of 8 cancers, especially bladder, breast, colon, endometrium, esophagus, kidney, lung, and stomach. And it also works on healthy weight, reduces risk of weight gain, and improves bone health and reduces risk of falls. So working on balance and coordination. Okay, any question? Okay, for adults age between or age 65 years and above, it's same as for adults, so same procedure or same program. In addition, and as a part of their weekly physical activity, older adults should do varied multi-component physical activity that emphasizes functional balance and strength training at moderate or greater intensity. It's better to be on 3 or more days a week to enhance functional capacity and to prevent falls. So as you can see here, it works on if the seniors or the older elderly people or the senior exercises. It works on the immune system. A strong, healthy body can fight off infection and diseases more quickly. It works on also on healthy brain. Studies here have shown that exercise can reduce the risk of Alzheimer's disease and other dementias. The exercises for elderly senior also work on heart health. Exercise lower the risk of heart disease and high blood pressure, and it improves the sleep, and also it helps to prevent bone loss, which reduce the risk of osteoporosis and accidental falls. And on the digestion, exercise aids in waste elimination and the function of your of the gastrointestinal tract. So, as per, for example, I can give some examples here. Moderate intensity, for example, moderate intensity aerobics activity for the elderly senior people, such as walking for 150 minutes, for example, 30 minutes a day or over 5 days a week. Also, it's good to do the muscle strengthening activities 2 or more days per week. As I said, it can strengthen the muscles group of legs, hips, legs, abdomen, chest, shoulder, and arms. And also the balance activity like walking backward, standing on one leg, or using a wobble board about 3 times a week. So it's good. It can be with assistance or without. Depends on the capacity of each person. And for another example, when we said before about the vigorous intensity aerobic activity for 75 minutes, it's around 1 hour, 15 minutes every week. And to do like 2 or more days a week, that they should do muscle strengthening activities also for all the muscles group, and do the balance activity 3 times a week. So this is some examples, and now we move to the pregnant and postpartum women. All pregnant and postpartum women without contradiction contraindication should do at least 150 minutes of moderate intensity aerobic physical activity throughout the week. Incorporate a variety of aerobic and muscle strengthening activities and should limit the amount of time spent being sedentary. Replacing sedentary time with physical activity of any intensity, including light intensity, provides health benefits. So, if you want, according to the physical activity guidelines for Americans, it's the second edition of this of the guidelines. Pregnant or postpartum women should do at least 150 minutes, for example, 30 minutes a day, 5 days a week, of moderate intensity aerobics physical activity per week. Also, they can do vigorous intensity, such as running, can continue doing so during and after their pregnancy. Also, according to scientific evidence, the risk of moderate intensity aerobic activity, such as walking, or very low for healthy pregnant women. Physical activity does not increase the chances of low birth weight, early delivery, or early pregnancy loss. Here in this figure, we can just see the benefits from exercises during pregnancy, going from controls maternal weight gain to improve mental well-being and body image, reduce risk of gestational diabetes, or reduce risk of preeclampsia, reduce risk of hypertension, reduce pelvic and lower back pain, reduce risk of acute cesarean section, reduce risk of prolonged labor and instrumental delivery, reduce risk of macrosomia, reduce the risk of preterm delivery. So the benefits of the activity, it's like this chain, and it's as we know, it's always good for pregnant people to train and to do exercises. So for people living with chronic condition, if we want to talk about people living with chronic condition like hypertension, diabetes, HIV, cancer, etc., they should do at least also 150 to 300 minutes of moderate intensity, or 75 to 150 of vigorous intensity aerobics physical activity, or an equivalent combination of moderate. So it's a combination between the moderate and vigorous intensity aerobic physical activity. And should also do muscle strengthening activities at moderate or greater intensity that involve all major muscle groups. And also, as a part of their weekly physical activity, older adults should do varied multi-component physical activity that emphasize functional balance, strength training at moderate or greater intensity on 3 or more days a week, always to enhance functional capacity and to prevent falls. For people living with also with chronic condition, as we said, so they can also increase the moderate intensity aerobics physical activity to more than 300 minutes, or do more than 150 minutes of vigorous intensity. So from 75 to 150 minutes, and from 150 minutes of moderate intensity aerobics to 300 minutes. And always they can combine between moderate and vigorous intensity activity. And they should limit the amount of time spent being sedentary. It's not good at all. They should stay active and keep moving and do exercises. Replacing sedentary time with physical activity of any intensity, including light intensity, provides health benefits and also helps reduce the detrimental effects of high levels of sedentary behavior on health. All adults and older adults should aim to do more than the recommended levels of moderate to vigorous intensity physical activity. For children and adolescents living with disability, for children with disability and adolescents also with disability, they should do at least an average of 60 minutes, so it's less than the others. 60 minutes per day of moderate to vigorous intensity, mostly aerobic physical activity across the week. Also should incorporate vigorous intensity aerobic activities as well as those that strengthen muscle and bone, at least 3 days a week. They should limit also the amount of time spent being sedentary, particularly the amount of recreational screen time. For adults living with disability, it's the same as the others, should do at least 150 to 300 minutes of moderate intensity aerobic physical activity or 75 to 150 minutes of vigorous intensity physical activity. And should also do muscle strengthening activity at moderate or greater intensity that involve all major muscle group on 2 or more days a week, as this provide additional health benefits. So this benefits, like if you want, supports daily living activities and independence, immediately helps you feels function and sleep better. So also helps control weight and improves mental health by reducing depression and anxiety, and lower the risk of early death or heart disease, type 2 diabetes, and some cancers. Also, these activities help to decrease pain and improves function in people with osteoarthritis, for example, improves cardiovascular health, muscle fitness, and brain and mental health. Some example of physical activity for people, adults living with disability, like walking if they can walk, or wheelchair rolling, or biking if they can bike, swimming, or water aerobics if they could do they can do this. Muscle strengthening, some yoga posture, it will be good. Strengthening exercises using exercise bands, weight machine, or handheld weight. As we can see here in this figure, disabled adults, they benefit from the exercises. They should make it like a daily habit. It can, so being inactive is harmful to health, and they should not be still for too long. Physical activity makes them feel good. So improve mental health, makes maintaining a healthy weight easier, makes daily tasks easier, and increases independence, strengthens muscles and bones, improve fitness, improve mobility and balance, helps to prevent chronic disease, and creates opportunity to meet new people and feel part of the community. In children and adolescents, physical activity improves physical fitness, like cardiorespiratory and muscular fitness. It improves also cardiometabolic health, like reducing blood pressure, dyslipidemia, glucose, and insulin resistance. And also it works on bone health, cognitive outcomes, like academic performance, executive function. It works also on mental health and reduce symptoms of depression and reduce adiposity. In adults and older adults, higher level of physical activities improve low risk of all-cause mortality, low risk of cardiovascular disease mortality, and less incident hypertension, less incident site-specific cancer like bladder, breast, colon, etc., less incident type 2 diabetes, prevent of falls mental health, reduce symptoms of anxiety and depression, cognitive health, improve sleep, and measures of adiposity may also improve. For pregnant and postpartum women, physical activity confers the following maternal and fetal health benefits: a decreased risk of pre-eclampsia, as we said before, as Dr. Anthony also said before, gestational hypertension, gestational diabetes also can decrease the excessive weight gain, delivery complication, decrease postpartum depression, newborn complication, and etc. So physical activity has no adverse effect on birth weight or increased risk of stillbirth. So this is here. Allow me to talk about the physical activity pyramid. So this pyramid is starting with the avoid excessive settings. If you can see in the bottom of the page, so avoid excessive sitting and exercise screen time. This is avoiding sedentary living and inactivity. So we start with this. So in this physical activity pyramid, you can notice three pictures intended to emphasize the importance of avoiding sedentary and inactive behavior. So this a person is sedentary when doing low energy activity, such as lying down and sitting. The picture below the pyramid are meant to discourage too much sitting and excessive screen time during the day. So we move to step 1, the moderate physical activity. So at this level, it's the first step in this physical activity pyramid should be performed daily or nearly every day. So it involves, if you want, the physical activities equal in intensity to brisk walking. Some activity of normal daily living, such as yard work, housework. It also includes sports that are not vigorous, such as bowling, golf. Some sports can be also moderate. For example, shooting basketball is typically a sport. Can be either moderate, like playing a full court game. It will be vigorous. It will not be moderate. So, like shooting basketball, only shooting, it will be moderate. Finally, national guidelines recommend 60 minutes of moderate to vigorous activity each day for teens. Moderate activity is the most common type of physical activity for most people. Moving to the step 2. The step 2 is the vigorous aerobics. So it's another level of exercises. It represents for example, jogging, swimming, hiking, and dance or aerobic dance. These activities at this step are intense enough to increase breathing and heart rate and make the person's not so vigorous that the body cannot supply enough oxygen to perform the activities for long period of time without stopping. So this is like moderate activity. They provide many health and wellness benefits, and they are especially helpful for building a high level of cardiorespiratory endurance. Step 3, it's a vigorous sports, recreation, anaerobic, and mixed fitness activity. So it's like, as we said, it's a recreation and sport activities. require your heart or the heart to beat faster than normal and cause breathe faster and sweat more. So it's a little bit more intensive. Unlike vigorous aerobics, vigorous sport and recreation often involve short bursts of activity, anaerobic activity, following by short periods of rest, like basketball, football, tennis, etc. These activities provide similar fitness, health, and wellness benefits to those of vigorous aerobics. They also help people build motor skills and contribute to healthy weight management. Moving to step 4, muscle fitness exercises. In this step, the physical activity represents muscle fitness exercises and includes both resistance training and moving at own body weight. So like rock climbing, jumping, etc. This type of exercise produces general health and wellness benefits, as well as better performance. Just to improve body appearance, a healthier back, better posture, stronger bones. So it's a high level, if you want, of activity. Finally, we have this step 5 before moving to energy balance. So the last step before the bottom, before the top. So it will be the physical activity flexibility exercises. Like evidence indicates that in this level, flexibility exercise and other activities that improve flexibility, such like yoga, tai chi, can benefit functional fitness, improve postural stability and balance, and reduce risk of falling among older people. Here there is also some evidence that flexibility exercises may reduce soreness and prevent injuries. And finally, arrive to the energy balance. So it's the top of the pyramid. So the top of the pyramid represents a balance scale. Balance scale, it's illustrating the need of energy balance, meaning that the calories in the food you eat each day are equal to the calories you expend in exercises each day. So it will be like a balance between both energy out and energy in. Energy out, it's activity. Energy in, it's the diet. So what we are eating. So energy balance is essential to maintaining a healthy body composition. Okay. Okay, let's move to social determinants of health to help prevent cardiovascular disease. So we have the topics or the domain and some example or consideration. Starting with the cardiovascular risk, adults should be routinely assessed for psychosocial stressor and provided with appropriate counseling. Healthy literacy should be assessed every 4 to 6 years to maximize recommendation effectiveness. What is this healthy literacy? Personal healthy literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Moving to the diet, it's a prescription of diet modification and the potential barriers to adhering to a healthy diet should be assessed. So in addition to this prescription of diet modification and body size prescriptions, as well as social and cultural influences, Potential barriers to adhering to a heart-healthy diet should be assessed, including food access and economic factors. These factors may be particularly relevant to persons from vulnerable population, such as individuals residing in either inner city or rural environment. So this is a disadvantage on those of age. Third domain is exercise and physical activity. In addition, of the prescription of exercises, neighborhood environment, and access to facility for physical activity should be assessed. So we have to assess if the people have the access to facilities and they can do their exercises and their physical activity. For the obesity and weight loss, the first domain, lifestyle counseling for weight loss should include assessment of and interventional recommendation for psychosocial stressors, sleep hygiene, and other individualized barriers. The weight maintenance also should be promoted in patients with overweight, obesity, who are unable to achieve recommended weight loss. Moving to the fifth domain, which is diabetes mellitus, prescription. So here we're talking about the prescription of type 2 diabetes interventions, environmental and psychosocial factors, including depression, stress, self-efficacy, and social support, should be assessed to improve achievement of glycemic control and adherence to treatment. So this is, we are talking about the social determinants of the help to prevent the cardiovascular disease. About the high blood pressure, short sleep duration, less than 6 hours, and poor quality sleep are associated with high blood pressure and should be considered, because other lifestyle habits can impact also on blood pressure, and access to a healthy low sodium diet and viable exercises option should also be considered. Moving to the tobacco treatment, social support is also another potential determinant of tobacco use. Therefore, in adults who use tobacco, assistance and arrangement of individualized and group social support counseling are recommended. So it's recommended they go to the group social support or individual support. So here some studies, starting with this, the study about walking as an opportunity of cardiovascular disease prevention. And this study, they were talking about increasing physical activity among adults at risk for or with cardiovascular disease can help prevent and manage the disease. So the increasing of physical activity, for sure, they can help prevent and manage the disease. And walking especially is an easy way for most adults to avoid inactivity and increase physical activity levels. So however, the prevalence of walking among people of various degrees of cardiovascular diseases risk is unknown. What is added by this report or this study? The prevalence of any walking decreases and increasing cardiovascular diseases risk even after adjusting for demographic characteristics. Similar pattern observed for leisure walking, but not for transportation walking. What are the implications for public health practice? Promoting walking, especially among adults at high risk, may present an important opportunity for encouraging active lifestyle for cardiovascular disease prevention and management. So this study is working on national representative data on walking from participants. It was around 29,742 people in the National Health Interview survey were analyzed. Participants were 51% women and 49% men. They estimated prevalence of walking three-way, so any walking, so we will describe them after. So transportation walking and leisure walking. Transportation walking was defined as a yes response to the question. During the past 7 days, did you walk to get someplace that took you at least 10 minutes? So the walking is a kind of transportation for the person. Leisure walking was defined as yes response to the question, during the past 7 days, did you walk for at least 10 minutes for fun, relaxation, exercise, or to walk the dog, for example? And the third one, it was the any walk. It means participating in either transportation or leisure walk. It was so any kind of walking. So as you can see here in this figure, we have in dark blue, the no cardiovascular disease and not at risk. Then we have the risk overweight or has obesity and one risk factor, overweight or obesity and two risk factors, overweight and obesity with three risk factors, and the light blue, it finally has cardiovascular disease. And so it's the percentage according to the diseases or non-cardiovascular disease or has cardiovascular disease in any walking or leisure walking or transportation walking. So prevalence of any walking among adults by cardiovascular disease status excludes respondent unable to walk. Error has bars represent the upper and lower bounds of the 95% confidence interval. Risk factors were hypertension, hyperlipidemia, diabetes, etc. So prevalence of any walking decreasing with increasing cardiovascular disease risk. So no cardiovascular disease and not at risk, 66.6%. At risk, overweight or one risk factor, 63%. Two risk factors and obesity, 59.5%. With three risk factor, obesity and three risk factors, 53.6%. And has cardiovascular disease, 50.2%. So after adjusting for respondent characteristic, the odds of any walking and leisure walking decreased with increasing cardiovascular disease risk. However, so cardiovascular disease risk was not associated with walking for transportation. So finally, as a conclusion, promoting walking may be a way to help adults avoid inactivity and encourage an active lifestyle for cardiovascular disease prevention and management. Also, another study about bicycling to work and primordial prevention of cardiovascular risk, a cohort study among men and women. In this study, researchers followed 23,732 men and women with a mean age of 43.5 years at baseline, who attended a health examination twice during a 10-year period. And multivariable adjusted models, they calculated the odds of incident, obesity, hypertension, hypertriglyceridemia, and impaired glucose tolerance, comparing individuals who commuted to work by bicycle with those who used passive modes of transportation. They also examined the relationship of change in commuting mode with incident of this clinical risk factor. At baseline, passive travel to work was the most common travel mode, and going with the car or something, followed by bicycling 24%, walking 11%, and irregular traveling 6%. They excluded participants if they reported being unemployed or retired at baseline. The number was 1,782. And if they had missing information on commuting mode, relevant covariates, and outcomes, cardiovascular risk factors, respectively, the number is 7,214, living up to the final number of participants, 23,732. As per the results, cycling to work at baseline was associated with lower odds of an incident, obesity, hypertension, and hypertriglyceridemia and impaired glucose tolerance compared with passive travel. Participants who maintained or began bicycling to work during follow-up and lower odds of obesity, hypertension, and hypertriglyceridemia and impaired glucose tolerance compared with participants not cycling to work at both time points, or who switches from cycling to another mode of transportation during the follow-up. Here's some numbers and evidences. A meta-analysis of 52 exercise training trials of more than 12 weeks duration, including 4,700 subjects, demonstrated an average increase in HDL-C levels of 4.6% and reduction in triglyceride and LDL-C concentration of 3.7% and 5% respectively. Also, a 44 randomized controlled trial, including 2,674 participants, have studied the effect of exercise, training, and resting blood pressure. The average reduction in systolic and diastolic blood pressure was 3.4 and 2.4 millimeters mercury, respectively. Average systolic and diastolic blood pressure decreased 2.6 and 1.8 millimeter mercury in normotensive subjects, and 7.4 and 5.8 millimeter mercury in hypertensive subjects, respectively, suggesting that exercises may serve as the only therapy required in some mildly hypertensive subjects. Okay. Do we have time? Yes. Okay. So a 44-year-old male. Allow me here just to speak about a case study. A 44-year-old male patient, 185 centimeter tall, with a body mass index of 28.6 kilograms. And he has a cardiovascular risk factors identified as hypertension, blood pressure around 14/10 or 140/100 millimeter of mercury. Smoker until 2 years ago, approximately 40 packs per year. Moderate alcohol consumption, occasionally moderate physical exercise like jogging or swimming, regular snoring, and no significant family history of cardiovascular disease. Also, essential arterial hypertension grade 1, impaired fasting glucose, suspected non-alcoholic fatty liver disease, mild hyperuricemia, vitamin D deficiency, metabolic syndrome, risk for a fatal cardiovascular event. What is the treatment target as per your opinion? Can I have some answers, please? I can just go back and tell you about the case study. It's 44-year-old male patient, 185 centimeters, 28.6 kilogram as per body mass, known as hypertension, blood pressure, 140 over 100, 140 over 100, smoker until 2 years ago, moderate alcohol consumption, occasionally moderate physical exercises, regular snoring, no significant family history of cardiovascular disease, essential arterial hypertension grade 1, impaired fasting glucose, suspected non-alcoholic fatty liver disease, mild hyperuricemia, vitamin D deficiency, metabolic syndrome, and risk for a fatal cardiovascular disease. So for you, what is the treatment target? Okay, what else should take? Okay, blood pressure control, diet, sleep study. Okay, any other answers? Okay, so as Khalid said, blood pressure control for sure. So we should try to make the blood pressure less than 140 over 9, LDL cholesterol less than 150 milligram, 115, and the patient was recommended to, as per your opinion, what can we recommend for this patient? So we said that the target is to lower the blood pressure and lower the cholesterol also. What can we recommend for this patient? Daily physical activity. Okay, Ragad. Mr. Ragad, thank you. Any other answer? So increase the level of physical activity and to modify diet, increase the proportion of vegetables and fiber at the expense of saturated fat from butter and cheese, for example, avoid excessive salt intake. Yes, thank you, Masad. Diet. Anhar Kamal with blood pressure medication and lowering medication, yes. Medication for hypertension, that's it. The patient was, however, reluctant to accept a lipid lowering drug and wished to await the effect of lifestyle change. Okay, after 2 months of follow-up, the patient weight was unchanged, unfortunately. So at 98 kilogram, and both blood pressure and LDL cholesterol were lower. Blood pressure 130 over 85, LDL 142. The patient reported that he had failed to intensify physical activity. The patient was again motivated to do what? So what we can ask the patient or how we can motivate the patient. Intensify lifestyle change, and he was strongly recommended to increase physical activity 2 to 3 times per week, 45 to 60 minutes at least. Endurance training. The patient was reviewed again 3 months later. Physical performance capacity of the patient significantly improved. Blood pressure was well controlled on treatment. LDL cholesterol decreased by 39% and is within the recommended target range, HDL cholesterol increased by 21%, and the triglyceride slightly improved. Drugs for lowering cholesterol have not been required. So with this, we finish with the prevention, the physical activity and primary prevention of cardiovascular disease. There is just a quick overview and like reminder of about the nutrition. I know that you had it with you have it with Dr. Anthony, but just a quick review. So eggs and dietary cholesterol. So blood cholesterol concentration rise in response to cholesterol in food. We know that the nutrition is very important in cardiovascular disease prevention. So just a quick review. So is the eggs is recommended or no? Patients to significantly limit intake of dietary cholesterol in form of eggs or any high cholesterol foods to as little as possible. So one large egg has about, for example, 186 milligram of cholesterol. So if the diet contained little other cholesterol, according to some studies, eating up to an egg a day might be an okay choice. So one per day is okay. Vegetable oils vary greatly in the content of saturated fatty, as Dr. Antoine said before. There is clear evidence for olive oil for a benefit in cardiovascular disease risk reduction. As per the coconut oil, there is like a recent review of 21 research paper, 8 clinical trials, and 13 observational studies say that coconut oil raises triglyceride and LDL. So people who thought that coconut oil is good for cholesterol, this is wrong. Antioxidant evidence suggests that fruits and vegetables are the healthiest and most beneficial source of antioxidant for cardiovascular disease risk reduction. Is it good to add high dose of antioxidant dietary? Be aware that there is no benefit with the addition of high dose antioxidant dietary supplement. So that we can just take a moderate amount of this kind of fruit. Nuts for cardiovascular health. Incorporate of nuts into healthy dietary pattern has been associated with improvement with cardiovascular disease risk factor. Portion control is necessary. So the fatty acids in nuts are unsaturated, contain complex carbohydrate, fiber, and protein. So it's good for sure to add this nuts to our diet. So patient to incorporate nuts isocalorically in the diet by substitution of other food. Green leafy vegetables has significant beneficial effects on cardiovascular disease risk factors and is associated with reduced cardiovascular disease risk. The benefits, so studies have shown decrease in blood pressure, reduce atherosclerosis due to antioxidant and anti-inflammatory properties in the leaves. So juicing, here we should be a little bit careful. Data is insufficient. Whole food consumption is preferred, so it's better to take the fruit, the whole fruit. Juicing concentrate calories, leading to ingestion of excess calories, and it's important to avoid the addition of sugar in the juice. plant-based diet, evidence indicates improved cardiovascular disease risk factor, reduced coronary heart disease progression, and beneficial effects on cardiovascular disease. A vegan diet is devoid of all animals product and eggs. A vegetarian diet is typically a non-meat diet, but can include milk, products, and eggs. All plants contain protein in variable amounts. Dairy should be limited or not. Full fat dairy products are major source of saturated fat and sodium and should be limited. Reduced fat dairy products are convenient source of some essential vitamins and mineral and high quality protein. Coffee and tea, as Dr. Antoine said, coffee is good, and green tea also. So 500 milligram per day, equivalent to 4 to 5 cups of coffee, will be good. So coffee-based drinks with sugar and fat reduce the health benefits. So if we add sugar and fat to the coffee, it will not be good. So it will reduce the health benefits. For the tea is very good, especially the green tea, but without adding sugars or sweeteners or milk and cream. Legumes low in fat, rich in protein and complex carbohydrate. We have in the legumes, we have the polyphenols, which have cholesterol lowering properties, decrease the cardiac health, and increase the cardiac health, and reduce post-potential blood sugar and insulin excretion. Mushrooms, it's very good to know about the mushrooms. There is no high quality evidence. Mushrooms may be associated with improvement of inflammatory and antioxidant pathways and may have beneficial effect on known cardiovascular disease comorbid risk factors. So the mushrooms contain vitamin D. It's a vitamin D producer, so contain ergosterol that convert to vitamin D when exposed to the UV light, and also lower the risk of breast cancer. Okay, I think as a take-home message to finish with this, the most important way to prevent atherosclerotic vascular disease and heart failure and arterial fibrillation is to promote a healthy lifestyle throughout life. Second message, a team-based care approach, an effective strategy for the prevention of cardiovascular disease. Clinicians should evaluate the social determinants of health that affect individuals to inform treatment decisions. All adults should consume a healthy diet that emphasizes the intake of vegetables, fruit, nut, whole grain, lean vegetables, or animal protein and fish, and minimizes the intake of trans fats, red meat, and processed red meats, refined carbohydrate, and sweetened beverage. For adults with overweight and obesity, counseling and calorie restriction are recommended for achieving and maintaining weight loss. Adults should engage in at least 150 minutes per week of accumulated moderate intensity physical activity, or 75 minutes, as we said, per week of vigorous intensity physical activity. Message number 5, all adults should be assessed at every healthcare visit for tobacco use, and those who use tobacco should be assisted and strongly advised to quit. Thank you so much. If you have questions, I'm ready to answer. Any question? Okay. We're gonna process with Dr. Anthony.
Okay, I will share my screen.
Okay. So it's the last session for today, and then we gonna see you tomorrow at 8. So the last session with Dr. Antoine, smoking cessation in the prevention of cardiovascular disease. Thank
Dr.
you,
Eli,
Dr.
please can you stop sharing your screen so I can share mine?
Yep. Yes. Okay.
Okay. Okay, it's good. Are you seeing the slides?
Yes, it's good.
Okay. So in the last topic of today, we'll talk about smoking cessation and the prevention of cardiovascular diseases. So we start by a brief history about smoking. So in the last half century of disease and death from 1964 till now, we can say that around 34.2 million of US adults have smoked in 2018. So it's a huge number of smokers in a single country. And we have around 480,000 deaths each year from deaths directly related to smoking. So from cancer, from cardiovascular diseases, from other type of diseases related to smoking. It's a huge number as well. And we have a huge number also for costs. So 300 billion US dollars per year, medical costs and lost productivity, because as you know, heavy smokers tend to be less productive. So when working in a company, they will be less productive, so we'll have less income for a country. So it's an economic burden for a country and for the civilization. So it's a deadly disease with a lot of economic consequences as well. The good news is that cigarette smoking is going down. So as you can see here, if we compare, for example, 1999, we can see that adults 18 plus and high school students had a high percentage of smoking. But if we see in 2018 in this study, we can see that the number has decreased from around 34.8% to 8.8%. And we'll try to interpret why the smoking is going down, maybe because there's another alternatives to smoking that high school students and adults are using instead of smoking. We can see that there's a lot of disparities between smokers. For example, the race American Indians tend to smoke more than white race, 22.6% versus 15% of white smoke. As for the educational level, for sure, the most educated human beings tend to smoke less than non-educated human beings. So 3.7% only in the humans that have a graduate degree. And you can see as well that when the income of the individual is lower, so less than 35,000 per year, they tend to smoke more than people with a high income. So 21.3% versus 7.3%. And we can see as well that patients with disabilities and with limitations tend to smoke more in order to compensate their disability. And patients with sexual orientations that are not heterosexual, so they tend to smoke more. And patients with serious psychological distress, it's very logical, will find a higher number of smokers, 31.6% versus 13% that doesn't smoke. It's very logical to see these numbers, because, as you know, patients with psychological distress tend to be addicted to a lot of things, easier than patients without any psychological distress. So the 10 major conclusions that we can say when we look at smoking history, that smoking cessation is beneficial even at any age. So there's no age to stop smoking. Even at a later age, we can have benefit if we quit smoking. And smoking cessation improves health status and enhances quality of life. Smoking cessation as well reduces the risk of premature death and can add as much as a decade to a life expectancy. So if we stop smoking definitely, we can increase our life expectancy by 10 years, which is a very high number. And the smoking cessation also reduces the risk of many adverse health effects, including reproductive health, so not only cardiovascular health, reproductive, chronic obstructive pulmonary disease, cancer. So quitting smoking is also beneficial to those who have been diagnosed with heart disease and chronic pulmonary disease. So even when smoking has caused heart disease, if we are stopped smoking, we can stop the progression of the disease that was caused initially by smoking. So smoking cessation should be encouraged for every patient when we see in the hospital or in the clinic or anywhere else. So the key epidemiologic measure. So in the US currently, the number are improving. So 3 out of every 5 adults who ever smoked have now attempted to quit or have already quit smoking. So it's a good number. And smoking cessation, it's increasing the past 2 decades. So from 2000 to till now, 2023, we had increased number of smoking cessation, and this is because of counseling. So when we see a patient in the clinic, we'll try to tell him about the side effect of smoking, and we can use some type of medications that we will discuss later on in this session in order to help patient stop smoking, because we have new medications currently in the markets that help stop smoking. And we can see that 4 out of 9 adults that comes to the doctor in the clinic are not receiving adequate advice in order to quit smoking, which is not good actually. And when we need to give advice to a patient to stop, we need to give them advices according to the guidelines and evidence-based approaches. So as you can see here, we can see 4 curves. We see curves for different age groups. The curve on top, which is the associated with for patients above 65 years of age, and the curve on the bottom, which is the black curve, which is for patients between 18 to 24. And we can see that the percentage of patients that are quitting smoking is higher as we grow old. So it's higher for patients above 65, a lot higher. It's around 70% for patients that are above 65, but it's around 20% only for patients that are young, between 18 to 24. So it's very low. We need to try to increase this. And it's we can interpret this is because patients above 65 years already have cardiovascular diseases and cancers, for example. So they try to stop in order to slow the progression, while patients that are young are usually healthy patients. So there's no reason for them to stop smoking. And we should work on this aspect of smoking in order to prevent smoking in this age group. So the biologic insights, why we smoke and why we become addicted. There's a lot of variables in smoking addiction. The first one is cellular and molecular biology of nicotine addiction. So nicotine is a molecule that we can find in the brain. It's the molecules that induce addiction. So when we have increased glutamate transport, it can alleviate nicotine withdrawal symptoms and prevent relapse. So we need to work on increasing glutamate transport in the brain in order to try to prevent relapse, because when patients have nicotine withdrawal, they will tend to relapse more. So we need to work on increasing this glutamate transport. And nowadays, there's a lot of works on vaccines, which are vaccines used in order to help smoking cessation, because these vaccines will produce nicotine-specific antibodies, so they will block the addictive effects of nicotine, and they will aid smoking cessation. So the antibodies will work on the molecule, on the nicotine-specific receptors in order to stop the cycle. So smoking cessation, it will reduce a lot of side effects of smoking, and the main one is cardiovascular diseases and the associated coronary heart disease, which is a leading cause of deaths in the cardiac population. Coronary artery disease is a fatal disease if not treated. We can see also that there's a reduction in cancer. We have a lot of cancer that are associated with smoking. Mainly it's the lung cancer, and mainly the small cell lung cancer and the other types of cancers. We have also improvement of in reproductive health and infertility for patients that stop smoking, and for sure we have the most disease associated with smoking is chronic respiratory chronic obstructive pulmonary disease, COPD, which is directly induced by smoking, and it's irreversible. So we need to try to stop smoking before the end stages of this disease, which is lung emphysema. So we need to try to treat before we reach the end stage. Asthma as well was linked to smoking, and asthma tends to improve with smoking cessation. So we have a lot of health benefits of quitting smoking. It will improve health in general. It will lower 12 types of cancer, as we said, mainly lung cancer. It will lower the risk of cardiovascular disease, all cardiovascular disease without exceptions, and will lower the risk of COPD, as we said, lower the risk of improve reproductive health, and it will improve patients with COPD and will benefit patients at any age. So quitting smoking will benefit patients at any age, even for patients that have smoked for years and have smoked heavily. Even if they stopped, they will have some benefits when they stop. So it's very beneficial. As for we have health and cost benefits. So smoking cessation will reduce mortality, as you said, and increase lifespan by 10 years. It will reduce when we smoking. It will reduce the hospital costs and admissions and medical costs as well. So the economy will improve, and the smoking cessation intervention, so they are cost effective, because it's better to spend a lot of money to promote smoking cessation, because when patients stop smoking, it's more beneficial for the economic for the health economics. So how to begin smoking cessation? We need to have behavioral counseling, so with a psychologist, with a psychiatrist, with doctors, with a health system in general, and we can rely on cessation medications. We'll discuss this on a later slide. And combination of behavioral and medical therapy for smoking cessation is very beneficial, and we are seeing very good numbers for people that are stopping smoking because of this combination of therapy. So for the medications, we have nicotine replacement. All the medications are based on nicotine replacement therapy. So we have the nicotine patch, which is a patch that we put on the skin of the patients. It will deliver nicotine over 24 hours. And we have also the nicotine tablets, gums that the patient chew, and it will provide him with the bolus doses of nicotine, and patient can take multiple tablets per day. So we also have the e-cigarettes, the electronic cigarettes. Some data suggested that e-cigarettes helped in smoking cessation, but these data are not sufficient. And we can't rely on electronic cigarettes in order to stop the traditional cigarettes for now. We'll see this later. But if we need to use the electronic cigarette, we need to use the electronic cigarettes containing nicotine, and not the e-cigarettes that's not containing nicotine, because we need to target the nicotine pathway. So if we have to use it, we need to use some types, not all types work, for to promote smoking, traditional smoking cessation. So in order to, we have another way to promote smoking cessation is by increasing the price of cigarettes. Many European countries nowadays have very high cigarette prices, which will a lot of people, a lot of patients will not be able to buy cigarettes, so they will be obliged to reduce their consumption to cigarettes. And we need to use smoke-free policies in the restaurants and many public areas. And we need to use media campaigns, social media and traditional TV media. And we need to have comprehensive state programs to control programs. So we need supervision and an organization to supervise all this work. Or so it's it's a bit complicated. If we look back to the history of humanity, since 1910 and 1914, when we had the First World War in 1914, from 1914 till 1930, we had an increase in the smoking percentage of number of smokers per year, because we had a Great Depression in around 1930 when the Wall Street stocks has collapsed in the United States. So a lot of patients tend to smoke more because of the Great Depression. And as you can see, during the Second World War, we had another spike, and we reached around the peak of smoker percentage of smoker in 1970. And after that, there's a lot of campaigns that are that helped in reducing the smoking, and we had a lot of medications that helped also in tapering smoking. So it's good results. In 2020, the number has decreased a lot as compared to 1970. So it's positive thinking. So we'll talk a bit about the young populations that consume tobacco. You can see here on this curve, it's the patients that are young that use the traditional cigarette. We're not talking of e-cigarettes here, use the traditional cigarette. You can see that the percentage of smoker is going down from 15.8 in 2011 to 5.8% of young individuals. But if we look at this curve, you can see that the young individuals are dropping the traditional cigarette, but they are now using more the electronic cigarette. We have a peak of usage of electronic cigarettes from 1.5% in 2011 to 27.5%. So we had a decrease in consumption of the traditional cigarettes, and we have increase in consumption of the new electronic cigarettes. So this is a bit worrying for the future of the population. So how to fight this rise in smoking in the young? We need, as we said, the counseling approach, behavioral therapy. So with a psychologist, with a psychiatrist. We need to use sometimes medications like nicotine replacement therapy, and we have medications that act on the dopamine pathway, which are bupropion. But these medications are sometimes not approved for adolescents. So we need to avoid using medications and use more the cognitive behavioral therapy, which is a psychologic-based therapy. And we have a lot of campaigns. You can see this is a United States campaign that is trying to engage young smokers in order to help them try to stop smoking, because they had actually around 166,000 smokers, and around 70% they set a quit date, so they are trying to smoke, and 48% are using extra support, so as they are using medications, they are using cognitive behavioral therapy, and around 68% have completed the program, and they are now tobacco free. So it's a good signs, encouraging signs. So smoking is the most powerful preventive intervention in clinical practice. So if we stop smoking now, we'll have a lot of mortality benefit. We'll decrease the mortality rate, decrease the cardiovascular diseases. So it's very beneficial. It's the most powerful tool to decrease deaths. So smokers in the study that was published in the New England Journal of Medicine in 2003, you can see that smokers lose at least 1 decade of life expectancy as compared with those who have never smoked. And if we stop smoking before the age of 40, this will reduce the risk of death with continued smoking by about 90%. So smoking at an early age is very beneficial, because if we smoke, for example, at the age of 70, a smoker at the age of 70 for sure has underlying diseases, underlying cardiovascular disease, and maybe underlying cancers that is still undiagnosed. So smoking early before the establishment of the disease is very beneficial and reduces deaths by 90%. So smokers usually think that they are zombies, that they will not die even if they smoke. They will always tell that some people never smoke and they had cancers. So why should we stop smoking? You can always hear this statements from smoker. So as you can see here in the slides, smoking tobacco is a substance abuse and is very, very addictive. It's the most addictive particle that people can use. It's addictive at a rate of 32% as compared to cocaine and heroin, which are less, 23 and 17%. Alcohol is around 15%, and other stimulants and anxiolytics are less of 10% addiction rate. So the addiction rate of tobacco is very huge, and 32% is a very big number. So that's why patients we find sometimes difficulty in order to stop smoking for them. And why its addiction rate is high? Because it's a simple tool. It's very easy to use, and you can use it in public anywhere. So it's easy to become addicted to smoking. And now with the electronic cigarettes, you can see that it looks like the traditional cigarettes, but it has a lot of technology in it. You have a lot of components, air vents, and filter, and we have the tobacco that can be filled inside. So it's more like technology. So young people are like technology, so they tend to start smoking more with these new techniques. But both traditional cigarettes and the electronic cigarettes have a lot of effects on lungs and on the heart and on the airways, on blood vessels. And you can see here the dopamine, which is secreted by the forebrain. It's a region in the brain. It's the responsible for addiction. The dopamine is the neurotransmitter responsible for addiction, and it has a lot of receptors in the brainstem, and elsewhere in the body. So this is the mechanism of addiction in smokers. So it's mediated by the neurotransmitter dopamine. So if you can see here, if we dose, for example, the nicotine, so when someone smokes, you can see the green curve. It's a pulsatile dosage in the blood. So when you dose nicotine in the blood in the smoker, it's pulsatile. And in order to help smoking cessation, we need to administer medication to give us a similar curve to nicotine. So as a replacement, as a red curve. But now we are very low. We can see that the treatment we have the orange, which is the transdermal patch that we give over 24 hours. You can see it doesn't look like it's the nicotine that's found in the cigarette. It's a lot lower plasma nicotine level. So we're still not effective. And you can see the yellow one, which is the 4 milligram chewing piece, which also is below the average nicotine pulsatile that we see in smokers. So sometimes when you combine both treatment, we can have a curve that looks like the green one, but we're still below the curve. That's why the medication are not 100% effective in stopping smoking. Okay, so for the medication, we have a study that compared the placebo use to all medication we have. We have a medication called varenicline and nicotine patch. We talked about nicotine gum, and we have the bupropion SR, and we have the patch plus gum at the same time, and the patch plus bupropion at the same time. And you can see that nicotine patch alone will cause abstinence from smoking in 23.4% of patients, while when combining patch plus gum, we will have the highest rate of abstinence from smoking, which is 36.5%, and it is statistically significant. So combining the two treatment options is very logical to do in our daily clinical practice. So here we see another picture of the e-cigarette because sometimes they use this as a replacement to the traditional cigarette in order to stop smoking. You can see the mouthpiece, and you can see here the battery and the nicotine that need to fill in order to have the effect of the cigarette. And you can see here the evolution. This was the first e-cigarette created. You can see the second generation e-cigarettes that are pre-filled or refilled cartridge, so we can fill them manually. And we have the third generation, which is containing a tanks or mods refillable. And we have the fourth generation, which contains the most advanced technologies. It contains pod mods with pre-filled or refillable as well. So the technology is advancing day after day in the smoking industry. If we see this study in Canada that patients use vaping, vape is a form of smoking as well. So we can see that people that are between grade 7 to grade 9, you can see that in 2018, 2019, this one, we have 11.11% of smokers, which is a very high number, as compared to year 2014, where we had 3.2% of smoker. So we can simply conclude that these patients are using the new technologies instead of the traditional smoking, that's why we had a higher number of smokers. Same to grade 10 to 12 people. So we had the increase in smoking and vaping over the years. Another study in Canada, England, and the United States it showed similar results. We had increased smoking between 2017 and 2018 from new technology of smoking. In all the studies, we can see we had increase in the number and prevalence of vaping and smoking. So why Canadian use vape? So use vape, the e-cigarettes, because they did this study and this survey, they find that the smell they use in this vape is the reason of the addiction. So 50%, around 50% of people said that's the smell, and 35% said that it's fun and exciting to use it. Even for patients, so for the different age groups between 20 to 24, they also said the same. So it was the flavor and the smell, which was the most addicting part of vape. And you can see here another study published also in the New England Journal of Medicine in 2019. In this study, we can see that vaping-associated pulmonary disease cases has reached epidemic proportions. So we had a lot of vaping-associated lung disease. You can see if you compare August 2019 to September 2019, we had dramatic increase in lung disease associated with vaping. So if we study the e-cigarettes in general and we check the toxicity on the lungs, we see that we have a lot of toxicity in the lungs, so it will affect the airways. The airways will become hyperreactive, so will induce asthma, because asthma is a hyperreactive disease, and will increase airway resistance, so will induce chronic obstructive pulmonary disease at a younger age. It will also act on the host defense, so it will act on the immune system. It will decrease the antimicrobial activity. So when we develop a lung infection and we use antibiotics, the antibiotics will be less effective as compared to people that do not smoke, because of the narrowing of the airways and the inability to clear the pathogen and the secretions. And we have increased resistance of bacteria to host antimicrobial factor, which is very logical as well for the same reason we said. And it will also act on the alveolar component, will decrease alveolar development, so we'll have premature lung disease. It will increase level of necrosis and cytotoxicity on the lung parenchyma. So it's very toxic to the lungs. This was one study. Other studies said that the toxicity was less, so we don't have actually a 100% confirmation in the guidelines. So another study, which was published in the Journal of Allergy and Clinical Immunology in 2020, showed that vaping-related pulmonary illness and asthma increased. So we had increase in asthma prevalence in young individual that are using electronic cigarettes. And we had another study also in the BMG journal. It showed as well negative effects on the lung endothelium. We had impaired in gas exchange. We have alteration of the bronchial epithelium, and we have downregulation of the immune genes and inhibition of ciliary beating. So we have a lot of toxicity. We have toxicity on the epithelial cells, on the immune system, and on the gas exchange, as we said. Another one was published in the Journal of Respiratory and Critical Care Medicine. It showed that e-cigarettes will act on the innate lung response, so on the immune system. So it has a negative effect on the immune system and will cause aberrant neutrophilic response. So it will activate the neutrophils, which are the primary host defense mechanism in the body, and they will have aberrant function. So they will have increased risk of bacterial infection and other inflammatory conditions in e-cigarettes patients. Same here, another study. It showed that, as you know, we have aerosolized oil in the e-cigarettes. So when we inhale these oils, they will reach the distal airways and they will reach the alveoli, which will cause a local inflammatory response and will lead to a vital gas exchange. So for sure we'll have an impairment in gas exchange. This one as well showed a life-threatening bronchiolitis related to electronic cigarette use in a Canadian use. We had a lot of research in Canada concerning e-cigarettes, so they are investing a lot on the young generation in order to try to stop, eradicate the smoking pandemic in North America. So bronchiolitis is a life-threatening condition in young, and the patient was very critical as a result of direct e-smoking exposure. This was another one. We had also an outbreak of a pulmonary disease, of unexplained pulmonary disease. It was an inflammatory disease in multiple patients, and all of them were linked to vaping because they had the common risk factor of vaping. This was in September 2019. Now, what are the effects of the electronic cigarette? What are the effects of the electronic cigarette on the heart? So as you can see, when we inhale the e-cigarette particles, we have two pathways. The first one will have oxidizing chemicals, and we'll have this will promote inflammation in the lungs and elsewhere in the body, the bloodstream. So we'll have platelet activation and thrombosis. In any inflammatory state, when we have infection, we have COVID infection, for example, we say that there's an increased risk of thrombosis, and a lot of people have died from thrombosis and pulmonary embolism. So any inflammation will cause platelet activation and thrombosis, and will cause endothelial dysfunction as well. So both these pathways will reduce myocardial blood flow by thrombosing the arteries and coronary arteries, and will lead to coronary occlusion and myocardial ischemia and myocardial infarction, and finally sudden death. So it's a long-term process, but the end point of this process is sudden cardiac death from myocardial ischemia. The second pathway is the nicotine pathway. So the nicotine pathway, as we know, it will activate the sympathetic nervous system. Sympathetic nervous system will cause increase in heart rate, will cause vasoconstriction. It's a fight and flight mechanism. So it will lead to increased heart rate and vasoconstriction, so increase in blood pressure. Increase in heart rate will cause increase in myocardial contractility, so increase in oxygen demand. And at the end point will lead to increased myocardial demand for oxygen and nutrients. And this will also aggravate the myocardial ischemia, and it will lead to sudden death. Activation of the sympathetic system can also cause tachycardias, and very fast tachycardias like atrial fibrillation and ventricular tachycardias in patients that are prone. So this will lead also to sudden cardiac death. Okay. If we see this slide here, we can see here in males and in females, if we compare both to non-smokers. So non-smoker females, sorry, the slide is in French, but if we see here the blue curve, these are the smoker females, and the red curve are the non-smoker females. And here on the second one, these are the smoker males, and these are the non-smoker males. So you can see there's in smokers we have decrease in incidence of life in smoking. For example, for an age of 70, for patients that we can see there's about 10 years reduction in life survival according to this. 11 years and in females and 12 years in male, which is a lot. So here as well, we can see that young females are being affected also by smoking. You can see that young patients are having increased myocardial infarction. So before we tend to see very low rates of myocardial infarction, but nowadays we see a lot of myocardial infarction in patients that have less than 45 years of age. And if you can see these patient characteristics that are less than 45 and develop a myocardial infarction, you can see that 80% of them are smoker. So smoking is very linked to premature myocardial infarction at a young age. Okay. So incidence of myocardial infarction increase in young females as well due to smoking. As you know, young females are in the premenopausal period, have estrogen and progesterone hormones, which protect them in the early years from developing myocardial infarction. That's why you see more males developing myocardial infarction as compared to female at the young age. But with smoking, the beneficial of these hormones, female hormones, is now going down, and we are seeing a lot increasing number of myocardial infarction in university hospitals or big hospital. You can see, for example, once a week or once every 2 weeks, a young patient in the 30s or in the 40s coming for a myocardial infarction in a large territory. So you can see here as well, it has smoking has an effect on the abdominal aorta. So we had times 3.5 increase in abdominal aortic aneurysm. So abdominal aortic aneurysm is a dilation of a part of the abdominal aorta. So above 4 centimeters or above 5 centimeters in size. And that's why it's recommended for every patient that has smoked, a male patient mainly, because male has a higher risk of the aortic aneurysm, is to do a routine screening abdominal ultrasound to detect abdominal aortic aneurysm once in their life after 55 years of age. So we should promote this idea because we know that smoking has a lot of increase in incidence of abdominal aortic aneurysms. So now if we can see this graph is about the risk factor to develop heart failure. You can see that the most common cause of heart failure is coronary artery disease, which accounts for 61.6% of cases. But you can see that smoking is now the second leading cause of heart failure, which is a big number. So smoking is now before hypertension, before low physical activity, before sex, before education, before overweight, before diabetes. So diabetes is just 3.1% of heart failure. So smoking is 6 times more, it can cause heart failure 6 times more than diabetes. So it's an essential cause, a primary cause of heart failure. So you can see here in this graph as well that e-cigarettes have caused more vascular stiffness. So we had arterial stiffness, and when we have arterial stiffness, we'll have stiff vessels, we have increase in blood pressure, we have increase in afterload on the heart, so we'll have increase in oxygen demand, so we'll have increase in myocardial ischemia. So as you can see here in this curve, the curve with the circles that are white, these are the e-cigarettes users, and the curve that are red are the non-smokers that inhale just air, and the others inhale all the particles of smoking and the e-cigarettes. So you can see there's an increase in arterial stiffness and increase in arterial elasticity, so we'll have increase in tension and blood pressure and cardiac death at the end. So here you can see as well, so we have increase in aortic vascular dysfunction. So the aortic valve and the aortic vessel, the aorta, you will see that these are all the risk factor for aortic disease, and you can see that smoking e-cigarette, if you see it here, it's in the middle. So it's a major cause as well of aortic vascular dysfunction as well. So it's a major cause. E-cigarettes as well, as we said, impair vascular function. So e-cigarette use should not be considered safe because a lot of patients are using e-cigarettes in order to quit the traditional cigarettes. So e-cigarettes should not be considered safe until now, and should be questionable as a harm reduction device. So it can cause harm as well. In a study published in 2018. Sorry. This is a study published in the Journal of Radiology. So this study showed that we have transient impairment of vascular reactivity, as we said in the previous slide. So the vascular elasticity will be less, so the vessel will be more tense. It will cause endothelial dysfunction, and it will cause impairment of the microvasculature of the vessel and of the level of the coronary arteries. So it will lead to acute aortic stiffness, and acute aortic stiffness will lead to a lot of diseases. Will lead to high blood pressure. It will lead to strokes because we'll have a lot of calcium deposits on the aortic wall, which can migrate to the brain. So it's a systemic disease, smoking. It's a pandemic causing systemic disease. So this study, they exposed mice, a group of mice, animals to e-cigarette smoking, and they detected increase in thrombogenesis and enhanced platelet function. So when we enhance platelet function, we'll increase platelet activation, so we'll increase thrombosis, and this will cause a lot of thrombosis, mainly in the coronary vessels, which is a major cause that lead to death as well. So if we want to talk of the effectiveness of this type of e-cigarettes, not just of the bad things, so we have limited evidence that it's effective in aiding traditional smoking cessation. So we have lacking evidence. We're not sure yet if it's aids or not. And there is moderate evidence from multiple randomized controlled trials that e-cigarettes with nicotine are more effective than e-cigarettes without nicotine for smoking cessation, because we said we need to target the nicotine pathway. We saw the curve about this before, so we need to target this pathway. And there is insufficient evidence from randomized controlled trials about the effectiveness of e-cigarettes as cessation aids compared with no treatment or to Food and Drug FDA approval. So it's still not very clear if it helps or not. But what we're sure of is that we have side effects coming from this type of smoking. And this is another study published in the Public Health Journal in 2018. It shows that e-cigarettes now have more difficulty in quitting e-cigarettes as well. So they used e-cigarettes in order to quit the traditional cigarettes, and now they have difficulties in quitting e-cigarettes. So we have less quitting even in the e-cigarettes group, and we can see that it's a meta-analysis. So it's grouped all these studies together and to come up with this conclusion that there is less quitting from e-cigarettes in the last years. So sometimes quitting vaping is harder than quitting the cigarettes alone. So ironically, we can say that using cigarettes to quit, they used another type of cigarettes to quit the traditional one, and now they have difficulties in quitting the new cigarette, a new technology. So this study showed that from every one patient that quit smoking, we have on the opposite side 80 kids that are starting to smoke. So the number is not reassuring at all, because for every one that stops, we have 80 that starts. So the number of e-smokers are increasing day after day. So the challenge is that these types of cigarettes have thousands of flavors, so it's difficult it's more prone to addiction, especially in young, and there's not a lot of regulation of these devices and technologies, and there's just minimal regulation for advertising. So the advertising, they play a huge role in marketing this technology. So we have high rates of youth addiction as a result and increasing rate of youth smoking. So the current approach will not yield regulation for years. So it will take a lot of years to fight the pandemic of e-cigarettes. So we need to try to implement flavor restrictions to ban any addictive substances that we use in these cigarettes. We need to use a plain packaging without a lot of figures or without a lot of marketing. We need to increase taxes and higher prices, especially to reduce the youth that smokes, because the youth tend to have more economic burden for them as compared to adults. And we need to increase nicotine levels in order to fight the pathway of addiction. And we need to ban some of the advertisement and to restrict age that for smoking. So now if we just will talk about a few slides on the guidelines that were published in the ESC 2021 guidelines, the most recent guidelines. The guidelines in class 1A level of recommendation suggest that all types of tobacco smoking should be stopped. And tobacco use is strongly independently causal of atherosclerotic cardiovascular disease. So it's direct linking with a cardiovascular disease. So we need to stop smoking, all types of smoking. And smoking cessation is recommended regardless of regain, because as you know, some patients, when they stop smoking, they will start to increase their weight as a compensatory mechanism. So they'll start to eat more. They start to eat unhealthy food in order to compensate and try to find another addiction other than the nicotine addiction. So they will increase weight. So it's even recommended to keep to eat more and to gain weight. It's better than to continue smoking. So we need to recommend smoking cessation even if they lose weight as a result of smoking cessation, because there's more benefit on the heart. So we need to ban smoking from public places, from restaurants, from libraries, from any public space. We need to ban smoking especially in places where young people are grouping there, and we need to restrict advertising and marketing that increases the sale of smoking of cigarettes. So we need to implement a complete ban on advertising on tobacco products, and we need to do restriction on advertising, as we said. All these are in the guidelines. So we need to use the social media, the telephone and internet-based lines in order to promote cessation of smoking. We need to use the media campaigns, mainly based on the social media, because to target the young generation, we need to target the social media first. And you need to reduce also the passive smoking. So passive smoking is when another person smokes, so we'll be exposed to the smoke. So we'll be a passive smoker. So we'll have also negative risk on the health. So we need also to ban smoking in schools for all the workers in school need to ban smoking, and we need to promote and teach on smoking prevention from an early age. Same applies for workplaces from large companies, and that's all the community in general. And one more thing, we need to recommend to advise pregnant women to be tobacco free during pregnancy, because smoking during pregnancy will have a lot of negative effect on the pregnant woman and on the baby as well. So we need to advise all pregnant women to try to stop smoking. And that's it. Thank you. Do you have any questions?
Any question?
Okay, so I saw a question in the comments. from Rawan, the patch, how it works. So the patch, we put it on the skin of the patient. We keep it for all day for 24 hours. It has a mechanism of releasing nicotine in the bloodstream, continuous release of nicotine in the bloodstream. So patients, when we have increase in nicotine in the bloodstream, so we will have less tendency to smoke because he wants nicotine from the cigarette. So when we give him nicotine from another pathway, this will help in smoking cessation. So that's the answer to your question.
Thank you, doctor.
Okay,
thank you, everyone, for your participation. And see you tomorrow at 8 p.m. Thank you so much.
Yes, so see you tomorrow. Thank you.
Thank you.